batch, you should have later on we will assess, and after 2-3 months, fine, if we feel the need, we will move on to the advanced version also, so that once you move out from this college, you will know how to deal with implants and you can practice with implants. So with this, fine, I will now take the opportunity to introduce to you our speaker for today. In this modern age, there is we have to have a balance between academics and clinician. Fine, some people are there who are very active into academics and some are very active clinicians. So our speaker for today, that is Vaibhav, he is a balanced mind and body between academics and clinicians. So it is my proud privilege to brief you about our speaker. So Dr. Vaibhav Tiwari, he did his BDS from PMNM Dental College, Bagalkot in the year 2005 and MDS from Periodontics from Kurg Institute of Dental Sciences, Karnataka in the year 2009. Currently, he is working as an associate professor in Government Dental College, Chhattisgarh, Raipur. He has been active in continuing dental education and has been giving lectures in various periodontics and mentored various implant workshops. That is the reason why we have him here, because he is a mentor in his periodontic society also. So he's very keen participant and a learner too. And he is the director of Chiranjeevi Dental Clinic at Raipur, where he performs everything from basic dentistry to periodontics to implants. He is the consultant periodontist and implantologist at various dental establishments. He is also pursuing his PhD from prestigious Sardar Pawar Dental College, Wardha, where he is attempting to regenerate one-wall defects. Fine, all of you must be familiar with one-wall defects. So he is trying to find out some bone graft materials and all so that he can regenerate those defects. He has also held various posts in local and state IDA, where he is continuously working for welfare of dentists in particular and general population at large. So he is currently serving as the president of Indian Society of Periodontists Study Group Johar and IDA Chhattisgarh branch. His field of interest include periodontal regeneration, implants and perioplastic surgeries. So with this brief introduction, I would now request Dr. Vaibhav Tiwari to please come and start the day's proceeding with his lecture.
Good morning, everyone. Thank you, Dr. Bishnupati Singh, for such kind words about me. It's always nice when your UG senior, praises you. That to someone whom you have looked up to when you are going through your being introduced to dentistry in BDS course. I would like to congratulate and thank Dr. Jayaprakash sir, Dr. Bishnupati sir and their entire team to have thought of this workshop. It's very important these days because Dental Council's curriculum does not do justice to implantology. So you always need something extra to get acquainted and familiarized with the procedures in implantology, because it in itself is a multidisciplinary task. It has some surgical components, it has prosthetic components. Basically, it is a field in which prosthodontics, that is restoration, fabrication of tooth, and surgery go hand in hand. So good morning all, and I'm here to welcome you all to World of Amazing Dental Implantology. When I say amazing, it's not a hyperbole. It's not exaggeration that implantology is amazing. It truly is, because it gives us the power. It enables us to treat cases so efficiently, such kind of cases which we had to settle for less than optimal treatment plan. So to familiarize you with the advantages of implantology, before we begin, I would like to go through certain clinical scenarios so that you can also get an idea of what implantology is capable of. This is a case I would like to direct your attention. There's a missing central incisor, left central. What would be our treatment plan for this case? Anyone from the audience? Come on, participate. Yes, please. FPD. Anything else? RPD. Okay. So conventionally, we had two options, removable partial denture and fixed partial denture like this, right? Now this is an RPD. Look at this. It's highly cumbersome. It's very discomforting and concerning to the patient because there is such a big plate that is inserted inside the mouth, which has this metal arms we call clasp, which will be hugging the tooth in order to keep the missing tooth or the abutment inside the mouth. It is very cumbersome, causes phonetic problems. Patient is always aware that he has something in his mouth which he has to keep inside. He has to be careful. Difficulties in chewing, plus the clasp which hugs the abutment tooth has deleterious effect on the abutment tooth. And lastly, it causes bone resorption. So it will become loose or ill-fitting in few days and the complications will increase. That is why, because of all these disadvantages, dentistry as a whole nowadays has discarded this treatment modality. Second option is fixed partial denture, very popular these days. What we have to do in this, you have to create abutments, right? Tooth preparation, hum sab padhte hain na, you must have done it in your preclinicals, step 1, step 2, step 3. So what basically you're doing is you're chopping down and compromising structural integrity of a healthy tooth, right? You are compromising structural integrity of a healthy tooth in order to replace one missing tooth. अभी ये बाजू वाले दांत पूछ रहे भाई हमारी क्या गलती, हमको क्यों मार रहे हो? Secondly, what happens is the lifespan of fixed partial denture as per literature is 5 to 7 years. In 5 to 7 years, not what patient expects from us, right? Now look at the dental implants. Implant will be acting as roots. First and most obvious advantage is that adjacent teeth are not touched. Secondly, it gives a natural feel. Aesthetics with dental implants, properly done implant restoration is as good as natural tooth. Secondly, there is something called chewing force. I don't know if you have come across any such patients, but seniors here must have come across a patient whom we have rehabilitated with FPD. Now everything is good. Nice occlusal table, width of the tooth. Nice occlusal table, very good occlusion. But patient comes to us saying that I'm not able to chew. Doctor, you have replaced my tooth. I'm happy, but I cannot exert sufficient chewing force. I'm not able to chew from this side. There's no problem, but chewing is not satisfactory. Why does that happen? What happens is that when the natural tooth per chewing cycle, it is subjected to around 750 lbs of forces. When you replace it with removable partial denture, it goes down to 150. FPD is slightly better, 500, but still not optimum chewing force can be exerted through FPDs. Implants, on the other hand, are capable of giving much better chewing force. So patient acceptance is also good. And lastly, longevity of implantations. The implant restorations are meant to last lifetime. There are studies, numerous evidence in the literature. How do we determine whether thing is successful or not? It's through the studies. Literature demonstrate n number of studies where the patients have been followed up for 25, 30 years, 2 to 3 decades. It's quite a long time. And implants have shown very high success rate in those time periods. So as far as these three treatment modalities are concerned, implants are head and shoulder above the other treatment modalities available to us. So what we did was we planned for an implant supported restoration of this tooth. Now look at the picture. Look at the natural appearance of the adjacent tooth. Can you make out, if you didn't know that this was the tooth that was missing, would you be able to make out the difference? This happens because this implant supported restorations seem to pop out from the gingiva, a phenomenon which we implantologists refer as emergence profile. It gives natural appearance. So this kind of results with so many benefits avoiding so many disadvantages of other treatment modalities are possible. And that is why we call, or at least I prefer to call, implantology. How did we start? Amazing. There is another clinical scenario. I would like you all to participate in this. See, this is a case who's suffering from severe periodontitis. Multiple teeth are mobile, hopeless prognosis. There are few which we can salvage through periodontal therapy. What would be your treatment plan? Come on, speak up. It's not a class, yeah. If you don't interact, no, we won't have that much fun. What would be? Say anything. Oral prophylaxis is one. When I say hopeless, there's no scope. Implants, I won't accept as an answer. Okay, implants is a good answer. That was my answer. No, you stole it. Anything else? See, if we set aside implantology, what are we going to do? What anyone can advise? Let us remove these hopeless teeth from here to here, maybe from here to here. Save whatever is salvageable through periodontal therapy, and then we'll go for a removable partial denture, simply because there are not sufficient number of abutment teeth for fixed partial denture. Now imagine what patient has to go through. First you'll remove the tooth, that too anteriors. Then you'll wait for the sockets to heal. You may give temporary partial denture, which is in itself is highly discomforting. So you'll wait for 3 weeks. Patient will have to be either edentulous or suffer to provisional partial denture. And then in the end, he'll get a removable prosthesis, which is in itself, we have discussed the disadvantages. Secondly, what happens in such scenarios is that there are certain dentists outside who say, दादा आपके 4-5 दांत बचा पा रहा हूं मैं, ठीक है, क्या फायदा उसका, निकाल देते हैं, बढ़िया सीडी बनाएंगे, आप मस्त खान. That is what usually happens in the clinic. Sadly, this is the scenario. But what we did was we planned to extract hopeless tooth, and we had planned plant supported denture. Now this is after extraction and placements of implant, and immediately we could give him provisional restoration. Imagine. This provisional restoration has better chewing efficiency than his original teeth. He can chew from these. Those mobile teeth, he was not able to chew anything. Immediately. And this is the final restoration after a few weeks. So we didn't leave him for even 1 day without tooth. We instantly were able to increase his chewing efficiency and aesthetics. This kind of results, this kind of efficient outcomes of such hopeless cases are only possible with dental implant. I cannot think of any other treatment modality. Another advantage of using implants is preserving the soft tissue. Look at this lady, a young lady, beautiful female who has pathological migration. Tooth is popping out. It has migrated so much so that when she closes her lip, tooth still pops out from in between lips. When we remove, and if we plan for a fixed partial denture, what will we do after removal? We'll wait for the healing to take place. When this heals, all these remaining tissues will be lost. And there will be a defect, right? In between the tooth, there will be a defect in the ridge. And you'll end up placing a long abutment tooth. Unusually long abutment tooth, right? But when you place implants immediately after extraction, you can get results like this. We were able to preserve all the gingival tissues. We were able to build upon the remaining bone, and look at the gingival profile. Patient displays gums while smiling. So look at the gingival profile. This is possible only with implantology. You can compare the pre-op smile and post-op smile. I don't need to say that notice the joy on her face, even though she has dirty teeth. Teeth has chlorhexidine stains which require scaling. So this kind of preservation of soft tissue and providing aesthetic results in sensitive areas is another advantage of implant. Lastly, look at this ridge. Patient was wearing a complete denture. What could his complaint be? Why would he visit a dentist? Any guesses? Yes, very nice. See the ridge in posteriors, it's almost flat, There's no elevation here, no elevation here. It's almost flat. So patient came to me with the difficulty of or inability to hold his teeth inside the mouth. And it's not a dentist's fault. Even best fabricated complete dentures in such scenarios will not give you satisfactory retention. Lower arch, he had 5 or 6 teeth, severely periodontally compromised. So what we did was, we removed his hopeless teeth from the lower arch, planned for all on 4 implant-supported denture, implant prosthesis, and an upper arch. When we took radiograph, there was no bone. See, the maxillary sinus has pneumatized so much that hardly 1 or 2 millimeter bone is here, hardly 1 millimeter bone is present here. Only amount of bone was present was between nasal cavity and maxillary sinus here, nasal cavity and maxillary sinus here. So we utilized those islands of bone, placed 2 implants there, and converted his existing complete denture into implant supported over denture at the same appointment. Placed 4 implants, placed 2 implants here with ball abutment. Now this is his preoperative picture. When I asked him to pose for camera and give me a smile, this is what he could manage. Can anyone tell me what is wrong with his smile? It's open to all. The question is open to all. Anyone? Somebody is saying shifted, somebody is saying something. This is the problem with we scientific minds. We always look for objective things. So I'll give you another objective thing. There is no upper lip visible. What is happening is he's trying to grab onto his denture. He's scared that it will fall off. And even in dentist's office, he's so scared that he's smiling like this. Right, pursing his lips inside. And this is after the treatment. His old denture is there. Look at the joy and ease on his face. Look at the confidence he's exuberating. Implantology is the only treatment modality that can give us the power to touch someone's life like that. So implantology is predictable, long-lasting, very, very integral part of dentistry, rapidly being accepted by the dentist. And for me, it is a crime if you don't provide patient with option of dental implants in your practice. So this is what dental implantology is capable of. Plus, there is something else when you perform implants, there is increase in income. Sabse bada rupaiya. So you get a lot of money when you place implants. Secondly, implantologists are admired by dental community. Your colleagues who do not perform implant, look at implantologists with admiration. So there is increased prestige among the colleagues. So these are the advantages. Now let us see this amazing treatment modality. How did this amazing treatment modality actually originated? If somebody tells you that implantology is a recent phenomenon, that is rubbish. Implantology, evidence of placement or implanting some material in the jawbone and making a tooth on top of it, is being performed since 2000 BC. Native Americans had their own form of implants where they implanted gold plates to hold the tooth. Egyptians had their own version where they implanted shells. Then there were so different attempts, different form and shape of implants like this one, subperiosteal implant, blade implant, transmandibular, ramus frame, and there are many more. All these things have been tried, but they didn't become popularized or they were not accepted by the dental community because either the success was very low, success rate was around 70% or something. Or if the success was good, they required very invasive surgical procedures with extraoral, intraoral, what you call incisions and all. So these things were not very accepted by dental community. The implants that we place today started from work of a great scientist, Dr. Per Ingeborg Brennemark. This great man wanted to study bone biology life, cellular event and blood circulation in live bone by placing such microscopes, endosseous microscopes, in tibia of rat. He was looking at how cells divide, how blood flow inside the bone, live, a living bone. When his experiment completed, he wanted to take his device out because they were very expensive. पैसे बहुत खर्चे थे उसने. So while removing, he realized that it is not possible to retrieve these microscopes without fracturing the bone, because titanium housing of these had fused with the bone. He called this phenomenon osseointegration. And this is defined as what you call direct structural and functional relationship between ordered living bone and surface of load-bearing implant. Basically, it is the process or is phenomenon of fusion of living bone with a metal that is titanium. So he called this phenomenon osseointegration. Let us have a look at what happens. How does this osseointegration take place at microscopic level? What are the events and why they are important to us? So I would like to direct you to this animation. Our bone is marvelous design which constantly rejuvenates by a balance between resorption and bone deposition. It is structurally designed so that the trabeculae or these spaces lie perpendicular to the force applied or perpendicular to the tooth. Has good blood supply. But what happens is, when we implantologists have a look at this bone, we start drilling on it. So we drill disturbs or destroys this natural architecture, resulting in tearing of blood vessel and destruction of bone to create a defect. We call it osteotomy. This defect is rapidly being filled by blood or hemorrhage. Once this defect is created, what we do is we place a titanium implant in this defect. Now, at this point, the titanium implant is in connection with the bone, or rigidity of the titanium implant is derived by screws or threads engaging in the bone. It's because the friction in the bone, between the bone and the implant. Okay. The stability or firmness of implant at this juncture, when we have placed it immediately, comes from the engagement of threads in the bone. Right? These threads. Can you getting it? This kind of stability is called primary stability. I'm just familiarizing you with the terms because I'll be using it a lot. Primary stability is when the stability is derived from frictional forces between the bone and dental implant. Let's move ahead. What happens next? We have placed an implant in our osteotomy wound. Now, there is an intense cell-to-cell interaction that takes place, leading to osseointegration. Initially, after placement of implant, phase 1 is hemostasis, that is stoppage of bleeding. That happens minutes after the surgery. The blood is oozing out through the tissues because of destruction. Tissue fibrinogen is present everywhere. So when the platelets come in contact with tissue fibrinogen or rough surface, they start adhering to the vessel walls like this. When they adhere to the vessel wall, they start plugging the gap from where the bleeding was originating. Additionally, these platelets secrete a lot of growth factors, such as platelet-derived growth factors, thromboxane A2. Now, thromboxane A2 is responsible for aggregation of more platelets into the site. And PGDF, transforming growth factor beta, is responsible for other cells to come and proliferate in the area so new bone can be formed. When platelets have finished aggregating, a meshwork of fibrin forms between the surface of implant and blood vessel and bone. This fibrin meshwork creates a fibrin clot by trapping cells in them. And this is very important thing because this will create a template for future bone formation. Bone formation will happen along with that. Few hours after the surgery, since even though we have fully strict protocols, some amount of oral bacteria manages to get inside the osteotomy. Few hours after the surgery, because of the secretion of thromboxane A2 and bradykinin, the gap in the blood vessel cells, endothelial cells, increases. This permits, come to the animation in a sec. This gap permits polymorphonuclear leukocytes to escape the blood vessel and come into the perivascular tissues. From there, like this, can you see this? This is neutrophil, polymorphonuclear leukocytes. So these neutrophil chemotactically move forward in amoeboid motion towards the bacteria. See, they are moving in an amoeboid motion. This is what happens inside the body. They start moving towards the bacteria or wound site where the bacteria is present. Like this. Once they have reached there, they start secreting different enzymes and reactive oxygen species like hydroxyl ion, hydrogen peroxide, nitric oxide, which starts killing the bacteria. Now, this phase is very important. If neutrophil and subsequently occurring macrophages kill off the bacteria, then normal healing will progress and what you call osseointegration will take place. But if they fail to kill the resident bacteria and bacteria start dominating, then wound breakdown will start and your implant will fail. So basically, whether your implant will survive or fail gets decided within first 24 to 48 hours. And it all depends on how good you have maintained the sterilization. These are the macrophages. After PMNs neutrophils have populated the area, in later stages, macrophages dominate. They phagocytize bacteria, phagocytize necrotic tissue debris post-surgically present to clean up the site. They secrete various growth factors. These growth factors dictate future events. One such factor is hypoxia-inducing factor. We'll come to it. This animation is showing release of growth factors from the macrophages. See? So one such growth factor is hypoxia-inducing factor. It creates a hypoxic environment, which leads to angiogenesis. We'll come to that. Plus, because of blood supply, you get a lot of other cells populating the area. This is a fibroblast, which is laying down what you call foundations for bone formation like collagen, elastin, and other fibers. These are perivascular cells. I was talking about hypoxia-inducing factor. They start migrating once they sense hypoxia in the wound defect site or wound site. These are stem cells. They can change into any cell like osteoblast, fibroblast, and angioblast, anything. So once they sense the hypoxia, they start migrating from the perivascular region to the region where there is decreased oxygen gradient. They start making or repairing the blood vessels by becoming endothelial cells, and subsequently they anastomose this new blood vessels with the previously existing vascular supply, thereby providing blood supply to the wound site, which is essential for any kind of repair. Simultaneously, osteoclasts also start appearing in the bone surface. Now, these osteoclasts start resorbing the necrotic bone debris so that they can create a healthy space for formation of new bone. Now that resorption creates a micro gap ranging to 100 nanometers. Once the bony debris is cleared, there is a gap of 100 nanometers between implant and the bone. This results in reduction in primary stability, temporary reduction. This happens between second and third week onwards. So this temporary reduction is compensated by, by presence of osteoblasts. These osteoblasts sit on the implant surface and simultaneously sit on the bony surface. So here there is osteoblast, here there is osteoblast. Implant, bone. Bone formation takes place and they join in the center. This completes the process of osseointegration or formation, fusion of implant into the bone. So what we saw that there is natural architecture of bone, trabecular bone is present. When we do osteotomy, phase 1 there is bleeding. Bleeding results in formation of fibrin clot, activation of platelets, growth factors. Because of presence of bradykinin in the area, blood vessels dilate. There is gap between endothelial cell which enable neutrophils to come out and destroy the bacteria. Later stages, neutrophil calls for help. Macrophages come, they start eating off the debris and bacteria. Once the defect site is clear, new blood vessels form simultaneously by perivascular cells. Proliferative cells like osteoclasts come to clear out dead bone and create a space between implant and bone. This space is later filled by osteoblasts who sit on the implant and the bone and start forming bone to complete process of osseointegration. This happens between 6 weeks. After that, when we load the implant, the bony remodeling continues and we get that pattern where the trabeculae are lying perpendicular to the alveolar bone. So this is what was discovered by किसका नाम लिया था हमने? Branamat, very nice. You are a good crowd here. I won't start that. So there are certain factors that are important for osseointegration to happen. One was sterilization. As we discussed in first 48 hours, if the bacteria are not cleared by leukocytes and macrophages and neutrophils, the wound breakdown and implant failure will pursue. Other than that, the implant has to be made up of biocompatible material. Titanium is material of choice. Some companies are using zirconia these days. That also offers a reasonable alternative or very good alternative to titanium. Then we discussed about primary implant stability, primary stability. That was the stability that comes from, very good, friction between the implant and the bone. So there has to be primary stability. Implant has to be stable, should not move around. Even micro movements of 150 nanometers can affect your osseointegration. Second is surgical procedure has to be atraumatic as possible to avoid less tissue damage so that your implant is surrounded by healthy tissue to osseointegrate. And there is an immobile and undisturbed healing phase that is required. I'll talk a little bit about titanium. Titanium is a biocompatible material, we all know, but what makes titanium biocompatible and inert? You know, in reality, titanium is very active material. The moment you expose titanium to air, a layer of titanium oxide coating forms almost instantaneously within nanoseconds. That reactive it is. It is that titanium oxide layer that renders it inactive. Plus, it is that titanium oxide layer that absorbs tissue fluid from the wound site into the implant. Absorption of fibronectin, tissue fibrins, is what allows osteoblast to attach to the surface of implant. So it's very important that there is an undisturbed titanium oxide layer. That is why, other than the sterilization, that is why we always say that when you take out implant, you don't touch it with your fingers or gloved hands. Or anyway, and no touching, take it out, put it back. Second is there are different grades of titanium available. हमारे प्रणब दा हैं क्या डीओ वाले? Pranabda will come to you someday and he'll tell, sir, my implant is manufactured with grade 4 titanium. So what is this grade 4? We must know to understand what he's trying to communicate to us. So there are different grades of titanium based on impurities, minute impurities present in the titanium alloy. Even though we call it commercially pure titanium, there are some impurities present. Grade 4 titanium is commonly used because it provides sufficient hardness. Greater the grade, greater the hardness. So grade 4 provides sufficient hardness and flexibility or tensile strength to withstand the forces that are going to be exerted on the implant. There are some grade 5 aluminum vanadium alloys that are also using, they offer better tensile strength and increased fracture resistance, but they have not been very aggressively manufactured. Then there is zirconia. I believe zirconia is the future of implant dentistry. One day, zirconia will replace titanium because of it offers similar biocompatibility, similar material desirable characteristics, plus it is white in color. It offers better aesthetics when used in endosseous implantology because metal may, be visible through the thin gingival tissue, but white zirconia will not have that grayish hue on the gingival tissue or even on the restorations. So we'll continue after the inauguration ceremony to explore further on dental implantology. Thank you.
Thank you, Dr. Vaibhav. I sincerely believe that it was a great start of the talk, and we were all so engrossed in your lecture on the dental implantology, but we will have a short break and we will carry on with the inaugural function. So first and foremost, I'd like to welcome our director, sir, Professor Vivek Kashyap, sir, to please come and take his seat on the dais. I request one lady doctor to please escort sir, and give him a bouquet of flower. Next, I request our very popular medical superintendent, sir, Dr. Hirendra Birua, sir, to please come on the dais. I request one of the doctors to please escort sir on the stage and present him a bouquet of flowers. Next, I request Head of the Department of Oral Surgery, Dr. V.K. Prajapati, sir, and Principal in charge to please take his seat on the dais. Last but not the least, our Head of the Department, Dr. Jay Prakash, MB, sir, to please come on the dais. Next, our own speaker who is here for 2 days to enrich us on dental implantology, Dr. Vaibhav Tiwari. May we request you to please come on the dais. I thank all the dignitaries on the dais for taking out their precious time and coming on such a short notice. Now I request all the dignitaries on the dais to please get up and do the ceremonial lighting of the lamp, and I request Shakti Sharma to come for the Ganesh Vandana. छोड़ दो।
वीर है गौरा तेरा लाडला गणेश, वीर है गौरा तेरा लाडला गणेश। माता है तू जिसकी पिता है महेश, माता है तू जिसकी पिता है महेश। वीर है गौरा तेरा लाडला गणेश, वीर है गौरा तेरा लाडला गणेश। अब मन के मैल से तन के मैल से पुतला बनाया, सत से उसमें प्राण जगाया, सत से उसमें प्राण जगाया। वीर है गौरा तेरा लाडला गणेश। जान जरा सी, जान जरा सी महादेव श्री दे। वीर है गौरा तेरा लाडला गणेश, वीर है गौरा तेरा लाडला गणेश। माता है तू जिसकी, माता है तू जिसकी, पिता है महेश। वीर है गौरा तेरा लाडला गणेश, वीर है गौरा तेरा लाडला गणेश। Welcome to all of these members we are presenting here. I'm really thankful to all of you.
Thank you, Shakti. May I request now our director, sir, to please come and say a few words of encouragement. Professor Vivek Kashyap, sir.
मंच पे उपस्थित हमारे एमएस साहब, डॉक्टर बिरुआ जी, प्रिंसिपल इंचार्ज डॉक्टर प्रजापति जी, डॉक्टर एमबी जयप्रकाश और छत्तीसगढ़ से आए हुए, रायपुर से डॉक्टर तिवारी, मेरे सामने उपस्थित जितने भी फैकल्टी मेंबर्स हैं और जितने भी टीचर्स, स्टूडेंट्स, आज एक डेंटल कॉलेज में एक नया अध्याय सा लगता है जुड़ रहा है, क्योंकि इस टाइप का, इस प्रकार का ये एक वर्कशॉप बाहर के फैकल्टी को बुला के कराना एक अपने आप में एक बड़ी उपलब्धि है। और मैं थोड़ा पहले चला आया था तो मैंने देखा डॉक्टर तिवारी ने बहुत अच्छे ढंग से और बहुत डाउन टू द अर्थ होके उन्होंने सारी बातों को आपको समझाया। इम्प्लांट्स के बारे में बहुत सारी बातें अभी आप लोगों को बताई जाएंगी। मेरा विश्वास है कि उससे आप लोगों को बहुत फ़ायदा होगा और इसे आप लोग अपने करियर एडवांसमेंट में काम लाएंगे। और ऐसे ही काम जो हम लोग करते हैं उससे हमारे इंस्टीट्यूट का नाम होता है, क्योंकि इंस्टीट्यूट केवल रोजगार देने का एक माध्यम नहीं होना चाहिए, मेरा जो अपना मानना है, क्योंकि ये कोई डेंटल क्लिनिक नहीं है। यहाँ पे हमेशा आपको सोचना चाहिए कि टीचिंग, ट्रेनिंग, रिसर्च, इन चीज़ों को बढ़ावा कैसे दिया जाए, कैसे इसे ऑप्टिमम लेवल पे लाया जाए। अब मुझे नहीं पता डॉक्टर वैभव अभी मेरे डेंटल कॉलेज को देखे हैं कि नहीं देखे हैं। इंफ्रास्ट्रक्चर काफ़ी अच्छा है, आप अगर नहीं देखे हैं तो जाके देखेंगे प्लीज़। और जो कुछ कमियां हैं मैं अपने ऊपर लेता हूं इसको, कि वो कमियां अभी पूरी नहीं हो पाई हैं, जैसे कि कंज्यूमेबल्स की कमी जो पहले से थी अभी भी बनी हुई है, लेकिन बहुत जल्दी हम लोग उसको सॉर्ट आउट कर लेंगे। उसी प्रकार हमारे बच्चे जो इंटर्न बन गए हैं उन्हें पेमेंट अभी तक नहीं मिला है, उसे भी हम लोग पेमेंट की दिशा में प्रयासरत हैं और मैं कोशिश करूंगा कि उन्हें पेमेंट जो है इंटरनल सोर्स से भी मिल जाए और बाद में जो बजट आए उस बजट से हम लोग उसको एडजस्ट करेंगे। इसके बारे में मैं बात करूंगा कि आप लोगों को पेमेंट जो है बहुत दुखद है ना, कि जब से आप लोग इंटर्न्स बने हैं कभी आप लोगों ने अपने कमाई का सुख नहीं देखा है। हाँ, आप हो सकता है कि आपके फादर मदर बहुत अच्छे हों, वेल ऑफ हों, सपोर्ट कर रहे होंगे, कोई दिक्कत नहीं होगी, लेकिन अपने कमाई का जो पहला सुख होता है, मुझे याद है जब मैं इंटर्न बना था तब, तो वो आप लोगों को भी मिलना चाहिए और बहुत जल्द मिलना चाहिए। इस दिशा में हम लोग प्रयत्नशील हैं। तो अक्टूबर में ऐसे भी सप्लीमेंट्री बजट जाना है, उसमें तो डालेंगे ही, लेकिन कोशिश ये रहेगी कि आप लोगों को उसके पहले हम लोग दिला सके। बस इन्हीं शब्दों के साथ, और खूब मन लगा के आप लोग काम करिए, खूब मन लगा के आप ध्यान से पढ़िए, समझिए, चीज़ों में आगे बढ़िए, क्योंकि यही आपको आगे ले जाएगा। मेडिकल कॉलेज, डेंटल कॉलेज, इन चीज़ों में असीम संभावनाएं हैं, बहुत दूर तक जाने की संभावना है और इसका कोई अंत नहीं है। कोशिश ये करनी है कि अपने एनर्जी को एक सही दिशा में आप चैनलाइज कर सके। धन्यवाद।
थैंक यू सर फॉर योर एनकरेजमेंट, और जो लॉन्ग टर्म डिमांड्स थे हमारे इंटर्न्स के, आपने उसको एड्रेस किया है, तो इससे बहुत हर्ष बढ़ेगा और उनमें एक नई उत्साह का संचार होगा। सो धन्यवाद सर। नाउ आई विल रिक्वेस्ट आवर हेड ऑफ द डिपार्टमेंट प्रोफेसर M.B. Jayaprakash sir to please give his welcome address.
A very good morning to all. Respected Dean Sir, Medical Superintendent Dr. Birwa Sir, Prajapati Sir, our guest speaker Dr. Vaibhav Tiwari, all dental faculty and dear students. It is my pleasure to welcome you all to the first ever CDE program on implantology, including hands-on course and live surgery, organized by the Department of Prosthodontics in Dental College, RIMS. Prosthodontics is the last resort of dentistry, as you all know. In the same way, implants are the last resort of restoration. When RPD or FPD is a failure or contraindicated, implant is the treatment of choice. Implant is also the modern and the current trend of treating edentullousness, because implants are next to natural teeth in restoring mastication, phonation, as well as aesthetics. Hence, I advise all the participants to make the best use of this opportunity and enlighten your knowledge as well as clinical acumen with surgical and prosthetic concepts of implantology. With best wishes, I would like to end my words. Thank you all.
Thank you, sir. May I now have the pleasure of requesting our Medical Superintendent, Dr. Hirendra Birwa, sir, to please address us.
नमस्कार, जोहार। आज के इस प्रोस्थोडोंटिक्स के वर्कशॉप में मैं इसके सफल आयोजन के लिए मैं सबसे पहले तो डॉक्टर जयप्रकाश एंड उनकी टीम को मैं बधाई देता हूं, और मंचासीन हमारे निदेशक महोदय, हमारे गेस्ट स्पीकर डॉक्टर तिवारी, हमारे डेंटल कॉलेज के प्रिंसिपल एवं सारे फैकल्टी जो यहाँ पे मौजूद हैं, और स्टूडेंट्स, स्पेशली इंटर्न्स जिन्होंने अभी जस्ट उन्होंने एक पहला कदम रखा है अपने प्रैक्टिकल ट्रेनिंग के लिए, सभी को मैं नमस्कार कहता हूँ, बधाई देता हूँ कि आप इस आयोजन के एक हिस्सा बने। ये खासकर आप लोगों के लिए होगा कि दिस इज हैंड्स ऑन ट्रेनिंग, so you get to know intricacies of all the implantology, as we have heard part of lecture just now, and I think you would be you will be enriched with the knowledge in these 2 days. And I advise you to make the best use of it. As already Dr. Jayaprakash has said, this is the first time ever such workshop has been organized here. And this is the best opportunity that you can have. Not only that, as our respected director has already said, that we are shortly we'll be getting consumables. So now this is the time to अपना रिजल्ट देने का टाइम है. तो हम आशा करते हैं कि अभी जो हमारे सारे विभाग है डेंटिस्ट्री के, सारे अपने फुल स्ट्रेंथ में काम करेंगे और हमारी जो इंस्टीट्यूट है उसको एक अगले स्तर तक ले जाएंगे. With these words, I once again congratulate you, all of you, for this organization and wish all the best for the next 2 days. Thank you.
धन्यवाद सर. अब मैं मंच पे बुलाना चाहूंगा डॉक्टर वी के प्रजापति सर को कि वो आकर के कुछ शब्द कहें.
जोहार. आदरणीय डॉक्टर विवेक कश्यप सर, हमारे मित्र और मेडिकल सुपरिटेंडेंट डॉक्टर बिरुआ, यंग एनर्जेटिक स्पीकर डॉक्टर वैभव तिवारी जी, डॉक्टर जयप्रकाश, हमारे प्रिय विद्यार्थीगण और इनवाइटेड डेलीगेट, आज का ये शुभ अवसर, विशेषकर आज का और कल का ये दिन हमारे विद्यार्थियों के लिए है. और हमारे स्पीकर साहब जो काफ़ी यंग एनर्जेटिक, पूरे डायनामिक रेंज ऑफ नॉलेज से भरपूर, इन्होंने डेंटल इम्प्लांट के लॉ को मुझे ऐसा लगता है कि पूरे देश में जलाने के लिए ये निकल पड़े हैं. इसका सारा बोझ अपने कंधों पे लेकर झारखंड की धरती पे जो जंगल, झील, तालाब और प्राकृतिक सुविधाओं से लैस धरती पे कदम रखा है, हमें उम्मीद है और पूरा विश्वास है कि हमारे विद्यार्थीगण इसका भरपूर सुविधा उठाएंगे. और ऐसा ही प्रोग्राम अगर ये होता रहे तो हम सब शिक्षक वृंद का ये कर्तव्य बन जाता है कि बच्चों के भविष्य को देखते हुए उनके सोच को और उनके उसको कलात्मक तरीके से एक नए आयाम में ढालने की कोशिश की जाए. रिम्स प्रशासन हर वक्त ऐसे कार्यक्रम में अपना सारा सहयोग देता आया है. एक छोटा उदाहरण है कि डॉक्टर कश्यप ने अभी तुरंत हमसे भी, मेरे से भी आते समय जानकारी लिया. इवन कल भी हम लोग इस विषय पर एक चर्चा कर चुके थे. जो 2 कमियां हैं जिनका उजागर सर ने किया, पूरी उम्मीद है कि इस वर्ष बहुत कम समय में ये पूर्ण होता हुआ दिखाई पड़ेगा. इसी के साथ इस कार्यक्रम में सहयोगी डॉक्टर विष्णु, डॉक्टर जयप्रकाश के टीम ने भी बहुत ही जबरदस्त काम किया. ये तो इसका असर देखने को मिल रहा है. उम्मीद है इस कार्यक्रम से सारे फायदा उठाएंगे. मेरी सारी शुभकामनाएं. धन्यवाद.
धन्यवाद सर. ये थोड़ा अलग होगा, बट चूंकि इनॉग्रल फंक्शन बीच में हुआ, इसीलिए मैं डॉक्टर मधु रंजन को बुलाना चाहूंगा कि वो अपना आकर के वोट ऑफ थैंक्स प्रस्तुत करें.
ऑनरेबल डॉक्टर विवेक कश्यप सर, डॉक्टर बिरुआ सर, डॉक्टर प्रजापति सर और स्पीकर डॉक्टर वैभव तिवारी, जयप्रकाश सर, esteemed faculty members and delegates. It's my privilege to have been asked to present a vote of thanks on this occasion. I, on the behalf of organizing committee, Department of Prosthodontics, Dental College RIMS, express our heartfelt gratitude to our speaker, Dr. Vaibhav Tiwari, to share his immense knowledge about dental implantology with us. I would like to thank Dr. Kashyap sir for giving us the necessary permission to conduct this workshop. I would also like to thank Dr. Birwa sir for his support and the time. I would like to thank Dr. Bhattacharya sir for letting us use the facilities at the trauma center. I would like to thank our principal, Dr. Ashish Jain sir, for continuously encouraging and guiding us. I would like to thank Dr. Prajapati sir and all the HODs in the dental college for the support. A lot of work has been done continuously by the organizing committee, so I would like to thank each one of them. Also, I would like to thank our sponsors, GSK, DG Ray, and Jail for their support. Last but not the least,
Thank you, sir. With this, we conclude the inaugural function and we will proceed with the lecture. So thank you, sir, for taking your time out from the busy schedule and coming and gracing the occasion. Thank you, sir.
Am I audible? Yes. देखो इम्प्लांट की बात होते ही स्टाइपेंड मिलना चालू हो गया तुम लोग. Congratulations. It's the sweet first income, stipend. So we were seeing that, in 1960s, Dr. Brennemar discovered the phenomenon of osseointegration. When this phenomenon was discovered and Brennemar described to people that, bone can fuse, titanium can fuse and merge and they can become one, people were still debating whether osseointegration is reality, whether osseointegration can happen predictably, that is, with how many times we place implant, and out of those times, how much percentage is there that get osseointegration. So people were debating that, but great man, found out application. He moved ahead and designed an application, real world application for his finding. He designed a device that would be fitted inside the human jaw and that will support prosthetic suprastructure. This is one of the first implants placed by Dr. Brennemark in 1970. It is the most basic type of dental implants, least advanced. And you see that even in year 2000, that implant is going strong. So if any one of you has any doubt about longevity of implant supported restoration, just look at this picture. This is least advanced dental implant, one of the first ones. It has served the patient lifetime. That patient passed away in 2006, I guess. Implant was still going in strong. How many of us see 30 years, 40 years lasting restorations? So dental implant longevity is beyond question these days. Now, to get this kind of long-lasting results or this kind of highly successful treatment, like with any other treatment modality, we need to do a proper treatment planning. Treatment planning involves diagnosis and determining the treatment options. So let us have a look at what we should see or look for in an implant patient when the patient walks to us. First is a thorough medical history. Implant being surgical procedure, medical history is of prime importance. A thorough history should be recorded, including his systemic conditions. We must look for the conditions that may require us to change treatment plan, or that might require patient's physician to change his treatment plan because we are doing treatment. Some medical conditions like diabetes mellitus, metabolic disease, which hinders with the healing. There are certain bone deficiencies like calcium phosphate metabolic disorders, which can lead to osteoporosis, leading to poor bone quality. So such conditions should be thoroughly investigated. Secondly, we must inquire about the medications patient is taking. You have been taught this since the third year of your BDS, so I won't go long. I would just name few important ones, like if patient is on antiplatelet therapy. Antiplatelet therapy may result in uncontrolled bleeding and difficulty in placing or performing the surgical procedure. Then there are certain drugs that interfere with bone metabolism, like bisphosphonates. They make bone brittle and prone to necrosis while in the healing phase. Then post-COVID era, we have to look for prolonged use of corticosteroids. Corticosteroids are immunosuppressants, so I don't need to tell that patient is more prone for post-op complication. Besides that, when individual is on corticosteroids, they develop a tendency towards delayed healing, slow healing. So we have to keep all this in mind. Next, we have to look for habit. One of the important habit in our region, your and mine too, is tobacco, chewing, gutka chewing, or smoking. Now, smoking is very important and crucial factor because studies show that smokers who are smoking more than 10 cigarettes per day for more than 10 years tend to have 50% more complications when treated with dental implant or any other surgical procedure for that matter than their normal or healthy counterparts. Secondly, smokers have tendency towards greater bone loss, pre-treatment and post-treatment. So we have to keep that in mind. Then radiation therapy is another important factor because radiation therapy creates hypovascularity, that is reduced blood supply, and hypocellularity. And we saw for osteointegration how much the cells and the blood supply is important. When we are determining whether a subject is fit for placement of dental implant or not, American Society of Anesthesiology's classification of patients comes to the mind. It was given to us by Sugarman et al. In 2000. It divides patient into 5 categories. ASA1 is normal, healthy individual. ASA2 has mild systemic disorders, but those disorders are not causing any functional limitations or threat to the life. ASA3 has severe systemic diseases which are non-threatening. ASA4 has severe systemic disease that has constant threat to life, like unstable angina. Unstable angina patient, you never know where he might have an episode. ASA5 is an individual who is not expected to survive for next 24 hours without surgical interventions. And ASA6 is a brain dead patient, basically a dead man whose organs are being harvested for donations. Since the dental implants are elective surgical procedure, we should not, humko koi mugalta nahi palna. We are performing elective surgical procedure which is aimed at improving aesthetics and function and quality of life of an individual. So it's an elective procedure, meaning that we can do it whenever we want. So if we have ASA1 and ASA2 patient, you can go ahead and place implants, no problem. But when it comes to ASA3, that is severe systemic disease, constant threat to life, or higher, we have to carefully evaluate whether patient or individual is fit enough to undergo our surgical procedure. And we have to weigh the advantages and the threats to balance it out. Because we can postpone implant placement procedure for till such a time when patient has recovered enough from his systemic diseases or illness that he can safely undergo the procedure. Safety of patient while performing a procedure, as well as safety of doctors and assistants, have to be kept in mind. So what are these events that we have to weigh? There are 2 kinds of events. One we call an absolute contraindication. That means implant should not be performed on them until unless patient has reached a status where it is safe to do the surgery. This include recent myocardial infarction. You have to wait at least 6 months for the last episode. Valvular prosthesis recently placed, again, is an absolute contraindication. Severe renal disorders, treatment resistant diabetes. Now, this is the word treatment resistant is important. That means that patient is taking medication, but somehow his blood sugar levels are not coming in the acceptable range. Such pain from doing implantology. Chronic or severe alcoholism, radiation therapy, drug addiction. These patients are uncoordinated. You cannot expect compliance from drug addict patients. Heavy smoking habits. Again, as we discussed, long-term smokers have reduced blood supply because of constant, vasoconstriction due to presence of nicotine and other cellular and immunological changes. So, smokers, we must have a candid conversation before performing implants and inform them about the situation that since you are a smoker, you have to drop the habit and you have to be prepared if there are any complication that arrives post-treatment. Then there are relative contraindications, situations that can be managed and implants can be placed. These include these situations directly relate to the severity of the disease, and clinicians' judgment in such scenarios is very critical. They include acquired immunodeficiency syndrome, is a relative contraindication. If you have low CD4, CD8 count, you have to refrain from placing. Prolonged use of corticosteroid, again, you have to evaluate the status of individual, how he is, how much potential he has for the healing. Phosphocalcium disorder, you have to evaluate the bone density, whether he is suffering from osteoporosis or something. Hematopoietic disorders, mild renal disorder, you have to evaluate the condition, whether you can administer your drugs post-operatively, intraoperatively, and patient can tolerate or not. Hepatopancreatic disorder, again, similar situations. When there are hepatopancreatic disorder, we have to keep an eye on INR and platelet count, because individuals suffering from liver disorder have tendency for bleeding, have tendency for low vitamin K, have tendency for reduced platelet counts. So this was the medical history, medical evaluation. Now coming to the intraoral examination. First and foremost thing we should be looking at when a patient walks in is whether there is availability of restorative space. Because patient walks into your clinic to get a tooth replaced. Is not bothered whether you are placing this implant, that implant, this kind of surgery, that kind of surgery. What matters to him, whether, when and where and what kind of tooth you will be placing. So it is important to evaluate whether there is sufficient space to place the tooth or not. For placement of implant supported restoration, there should be at least 5 to 8 mm of space incisor-apically in vertical dimension, and there should be sufficient horizontal space to accommodate appropriate size of tooth. For incisors, let's say it's around 8 to 10 millimeters, right? Then you have to evaluate soft tissue. Now this is very important. Important for the aesthetics, important for the longevity of implant-supported restoration. We need some amount of keratinized tissue. Period में आपको जब भी जाते हो, they would be asking you about attached gingiva, this, याद है? Attached gingiva is part of gingiva that is the only part of gingiva that is firmly bound to underlying bone. So that prevents movement of gingival margin when lips and cheeks are moving. अगर वो bone से नहीं जुड़ा रहेगा बीच में, तो when your lips and cheeks move, your gingiva will be pulled along with that. So that is why it is very important. It protects the marginal periodontium. Similarly, it protects marginal peri-implant tissues also. So when you are planning for implant, you have to evaluate whether sufficient amount of keratinized tissue is present or not, attached tissue is present or not. That you can do by sliding a probe if the tissue on the crest gets displaced when you're moving a probe from buccal to lingual like this, that means there is not sufficient keratinized tissue available. And you have to plan for a free gingival graft or some other treatment modality to create that attached tissue around the implants. Secondly, thickness of soft tissue is very important. We divide gingiva into thin and thick biotype. When we say biotype, it's a fancy word for thickness. We desire around 1 millimeter, at least 1 millimeter thickness of soft tissue. Thinner soft tissues, why? Because thinner soft tissues have tendency to harbor thin bone. And there is chances of dehiscence-like defect in the labial or lingual cortical plate that can complicate. So thickness of tissue gives us an idea about underlying bone. Secondly, there has to be a good gingival collar around the tooth. In thinner biotype, that becomes very difficult. We can assess thickness through an ultrasound probe like this, or we can simply use our normal periodontal probe or any other calibrated probe, place the rubber stopper that comes along with reamers and files, penetrate it, pull it out and see how much thickness we have got. Or then there is underlying bone status of alveolar ridge. When we think about that, there can be 3 types of scenario that we can encounter. First scenario, there would be sufficient height of the tissue bone, but there will not be sufficient width. That is, loss of or insufficiency of both horizontal dimensions like this. Height is good. You can place sufficient size of length of implant, but width is not good. Second scenario is width is good, but height is not sufficient. And third scenario is neither height is good nor width is good. So in the first 2 scenarios, if you encounter good height or good width, you can go ahead with implant placement along with bone augmentation procedures. But in scenario 3, where there is no height, no width, practically there is no bone. So first you have to create some bone with ridge augmentation, followed by placement of implant. Right? क्या करेंगे? When there is sufficient height or sufficient width, either of the two, what will we do? We'll place implant and bone augmentation together. But there is no height, no width. We'll do bone augmentation followed by implant placement. You can assess this by a simple technique clinically that is called ridge mapping. In this, what we do is we take impression, fabricate a cast, and cut the cast cross section in the center or in the region where we desire to place the implant. We fabricate a stent like this, which has holes through which we'll pass reamer. We'll place it in the patient's mouth, push the reamer till the bone, and then transfer those measurements in the cast via that stent. It will give you a rough estimate of what is the size and shape of the bone in that region if you mark these corresponding points. Additionally, you have something called ridge mapping calipers. You place it in the mouth, penetrate it till the bone level, and you'll get the readings in millimeter about how much width is there at that particular point of space. Visualization of treatment is very important. It gives you an idea of what kind of prosthesis you'll have to fabricate. Look at this case. When I do a wax up or a temporary, what you call visual aid, I can make out that, there is sufficient space available so that I can place the tooth in alignment or in contour with the arch form. But in some cases, where you have gingival deficiency, so if you place the tooth and arch is deficient, then your tooth will be popping out of the arch like this. So in such cases, you have to do a soft tissue replacement, either do a soft tissue augmentation along with the implants or do some prosthetic camouflage. So visualizing the treatment outcome gives you an idea or gives you an sense that what kind of treatment you need to perform along with implant placement to provide aesthetically acceptable prosthesis. Occlusal evaluation is a must. Again, it's about the space. There should be 5 to 7 millimeter space present for placement of tooth. If that amount of space is not present, then you have to do some kind of treatment, orthodontic movement, or you can chop it off so that you have sufficient space. Mesiodistally also 8 to 10 millimeter of space is required to fabricate any tooth. So if the space is not present, sometimes because of distalization and mesialization of adjacent teeth, you have to do an orthodontic correction so that you have sufficient amount of proper tooth in that region. So this kind of evaluation is very important. So after the clinical examination, we have to do a radiographic examination. It is a very integral part because it gives you an idea whether any pathology is present. Your implant bed, whether it is healthy or not, can be assessed by that. And secondly, you have to keep your distance from anatomical structures that are present in the maxilla and mandible. Can you name any anatomical structure in maxilla that can be of concern? Maxillary sinus. In mandible? You are very intelligent lot, I must tell you. So let's see anatomical structure. First is maxillary sinus. Fortunately or unfortunately, the largest paranasal sinus lie in the maxilla, just apical to molar and premolar teeth. And the floor of maxillary sinus is of particular importance to us because when tooth are extracted, sinus starts expanding and eating away the ridge. This can be visualized in an IOPA. Floor of the sinus can be seen. You can use a OPG to evaluate floor of the sinus, but these are two-dimensional representation of a three-dimensional entity. You may think that floor of sinus lies here, but in actuality, you see there is radiopacity here. So that means it is not a flat structure. It may be like this, sloping. For that accurate realization or visualization, you need three-dimensional radiography, cone beam CT. Cone beam computed tomography allows us to view the sinus in different sections. Sagittal section, axial section, these are the cross section. Now you see for this particular case, there is a septa present here, which could not have been seen in OPG or IOPA so clearly. Now this septa has to be accounted when you are placing an implant. You are not supposed to place implant in the septa because you might see bone here. Implant lagaya to thoda idhar se nikal hai. Then you can see the slope of sinus and you can assess that at the center what the actual height is. Because in buccal side sinus floor height is here. In lingual side it is here. But in two-dimensional, the floor of the sinus will be seen somewhere in between this. So you might think that you have 5 millimeter bone here, but in actuality at that point, because of the slope, bone was only 4 millimeter. So you'll end up drilling inside the sinus. So that is the advantage of CBCT. We are supposed to keep our implants at least 1 millimeter away from the floor of maxillary sinus. Secondly, floor of nasal cavity is another point of concern visualized in IOPS like this, two radiolucencies. It is seen in the central and lateral region. You can visualize it with orthopentamogram or OPG and with CBCT like this. We have to stay away 1 millimeter. We have to stay 1 millimeter away from the floor of maxillary floor of nasal cavity to when we are placing the implant. So if we have around 15 millimeters of bone here, the implant that we can place is maximum 14 millimeter. Reducing that 1 millimeter distance we have to maintain from the anatomical structure. Then incisive nasopalatine foramen incisive canal. It is best visualized in CBCT only because it lies in the posterior region that gets shadowed by tooth and bone present in front of it. So its location is best visualized in CBCT. When you are placing an implant in the anterior region, you can plan how much bone do you have anterior to nasopalatine foramen or incisive canal, and stay 1 millimeter away from it too. Mandible. Mandible is a complex structure, has ramus, body, angle, different parts. The most prominent structure or most sort of or fear, what you call the structure that drives fear in implantologist's heart is a mandibular canal. It starts in the ramus, travels anteriorly downwards, and emerges in the premolar region from the mental foramen as mental nerve, and sometimes continues anteriorly as incisive nerve. So we have to maintain a distance of 2 millimeters from this what you call inferior alveolar neurovascular bundle, because when you are placing the implant, simultaneously you are compressing the bone. If you go very near to the canal, even if you are not penetrating, you'll end up compressing the canal. That will put pressure on the nerve, and you'll have paresthesia. Paresthesia, bolo doctors ki tarah. Paresthesia. You can visualize it as two parallel radiopaque lines in two-dimensional radiographs like IOPA or OPG. In CBCT, another advantage is that you can visualize where your canal lies buccolingually. Sometimes, like in this particular case, canal is very lingual. Now you can plan an implant in this region provided that implant is narrow enough not to impinge on inferior alveolar nerve. So that kind of clarity can only come with CBCT, and you cannot assess whether implant canal is buccally or lingually with IOPS or OPGs. Secondly, there is another characteristic feature. What happens is, when a nerve is moving inside the body of mandible and emerging from the mental foramen, sometimes it makes a loop. Can you see? I have marked here in this picture. This is the inferior alveolar canal. You see, it is making a loop here and then coming out from the mental foramen. So whenever you are placing implant in canine and first premolar region, you have to be mindful about this loop. The length of this loop is approximately 3 millimeters. Then you have to have a safety margin of how many millimeters from nerve? Hey, structure nahi, nerve. 2 millimeters. So you have to stay away 5 millimeters, 3 millimeters for the loop and 2 millimeters for the safety margin. So you have to stay 5 millimeters away from the mental foramen if you are going apical in such scenarios. Mental foramen again found in the premolar region. You have to stay 2 millimeters away from the mental foramen if you are placing implant in first or second premolar. Then there is something typical in the mandible called mandibular concavities. There is submandibular gland fossa here. On top of it, there is mylohyoid ridge. So when you view from the top, you'll see that this much width is there. But as you move apically, the moment you cross mylohyoid ridge, it will become like this. This to this. So you have to be very mindful about mandibular concavities, submandibular fossa, and digastric fossa in the anterior region. If you do not plan for this, you may end up like this, where your implant is perforated the lingual cortical plate because you were thinking that, okay, from here I have this much of width, so I'll place it in the center. And when you went inside, the mylohyoid concavity below mylohyoid occurred and you perforated it. So to avoid this kind of complications, you have to plan keeping the concavities in mind. You have to either place an implant in this region or you have to tilt it slightly lingually. And in mandibular posteriors, 10 to 11 degrees of tilt, that is there naturally in the mandible. So we can tilt implant 10 to 11 degrees lingually in mandibular posterior. That compensates for this concavity and gives us optimum results. Then comes the bone. We are going to place implants in the bone. So characteristics of the bone are very important for us. First, we'll look at the density of bone. What kind of bone do we have? MITS classification is one of the most popular classification of bone densities, categorizing bone in D1, D2, D3, and D4. Now you see the normal architecture of our bone is what? We have a hard coating and a soft core. Eclairs की तरह है ये, right? Eclairs ऐसे ही होता है ना? How many of you had eclairs? So bone is like eclairs. Hard coating, soft core. Hard coating is made up of compact bone, and soft core is made up of trabecular bone. Now, presence or ratio of this determine the density of bone. In D1 type of bone, you have a very hard bone. It is very hard bone because compact bone is more, cancellous bone is less. In D2 bone, it is an ideal situation. Ideal situation for implantologists. There is perfect balance of hard and soft bone available. D3 gives a little jitters to the implantologist because the proportion of soft bone is more, and D4 is like a sponge, literally like a sponge. Have you ever come across the sponge? वो बुके में वो what do we call it? वो green सा रहता है जिसमें वो flower sticks लगा के बुके बनाते हैं. It is literally that consistency. If you apply finger pressure hard enough, sometimes you can compress it. So that needs to be consideration needs to be taken when you're doing implant. You have to take in account what kind of bone do you have. In D1 bone, we usually provide little wider osteotomies because we cannot compress it. How much can you compress already compact bone? D2, we go normal protocol. D3 also up to an extent normal protocol. But when it comes to D4, we make unusually small osteotomy, जो hole बनाते हैं, that is unusually narrow, little more narrow than the diameter of implant. And then we tighten it so that we can have sufficient amount of primary stability. ताकि वो tight fit हो जाए. Getting me? Not getting me? Feeling sleepy? भूख लग रही है? पक्का? चाय वाय पीना है? मंगाए? चलो फिर ठीक है. So that was about the bone density. D2 is the favorite bone of implantologists. D3 and D4 onwards, we have to do some additional measures that we'll be discussing later. Now, second is bone volume, amount of bone that is required. So when you are placing an implant, you have to be mindful that you leave at least 1.5 millimeters bone from the adjacent tooth on both sides, and at least 1.8 millimeter thickness of buccal and lingual plates. That has to be left. ठीक है? This 1.8 can be 1 but cannot be below 1, buccal and lingual side. So suppose if I am going to, I have 8 millimeter length. No, from this tooth to this tooth, I have 8 millimeter length. So what is the diameter that I can use? Very good. And if I have 6 millimeters here, .4, roughly 3, right? 0.6 तो measure नहीं कर पाएंगे. 1 millimeter रहना चाहिए, तो roughly 3. So keeping these factors in mind, we have to decide what type of, or what size or dimensions of implant we can place so that we have sufficient bony margin all around the implant. When you are using multiple implants, again, the law is same, little twisted. You have to have 1.5 millimeter here between the tooth and implant, 1.5 millimeter here between the tooth and implant, and 3 millimeters here between two implants. Basically, it's 1.5 idhar wale implant ka, 1.5 idhar wale implant ka, so it's 3 millimeter. So this spacing is very important so that you have sufficient amount of bone that can have sufficient blood supply for that bone to stay there, live and survive to support the implant. Right? Buccally lingually 1.8, mesiodistally 1.5, 1.5. Now we have assessed the what you call patient. We saw his medical history deemed fit. We saw the bone volume, good density, good volume. Now we have to choose what type of implants can I perform, right? So what are the types of implant that are there or that were there? We can categorize that implant designs into two micro designs, that is the microscopic texture of implant surface, and macro design, that is actual shape of implant surface. Some have tried the cylindrical implants previously. What we used to do is, if we are placing a 4 mm implant, we used to make a 4 mm implant, what you call osteotomy, and tap the implant inside that osteotomy. Now that was very difficult because it's very difficult to control the direction of implant. आपने कभी दीवार पे कील ठोकी है? You give one tap, you give two tap. एक बार तो ऐसा होगा कि वो थोड़ा टेढ़ा पड़ जाएगा और कील टेढ़ी हो जाएगी. कील टेढ़ी हो गई, निकाल के दूसरा लगा सकते, बट इम्प्लांट टेढ़ा हो गया तो क्या करेंगे? So it is that because of the difficulty in control while placing the implant in precise position, these implants were discarded. Next came the screw-shaped implants. Now, screw-shaped implants, what we used to do is we perform a little smaller osteotomy and then tighten it with a driver or a screwdriver-like device inside that hole. Now, because of the screws, it gave us precise control over angulation of implant while placing it in the osteotomy. So these became more popular than the cylindrical implant, which we had to tap into the osteotomy. Now again, after some time, there is another type of implant that came into the picture, which is very popular and being used nowadays, is root form conical implant. Now see, this is cylinder. Diameter is same, coronal to apical. This is tapering, conical. Coronal diameter is more, apical diameter is less. It enabled us to place implants in areas where bone was narrow apically, or in extraction socket when we are going for immediate implant, because in extraction sockets also the socket is conical, implant is conical, providing better fit. Coming to the micro design, we saw osseointegration. We saw that osteoblast come and sit on top of implant surface and deposit bone. So first, the Brennemark, when he started placing this implant, he used machine surface. That was smooth, polished, shiny surface. What happened was that since the microtopography of the titanium surface was not similar to the microtopography, when I say microtopography, think texture in a microscope. So microtopography or texture of smooth polished surface was not similar to microtopography of bone on which osteoblast is familiar with. The amount of osteoblast sitting or rate of osteoblast sitting on top of implant was less. So we started texturing the implant surface to mimic micro roughness of the bone so that osteoblast will become very friendly with the implant surface कि यार ये तो अपने घर जैसा लग रहा है और वहां आके बैठ जाएगा और bone deposit करेगा. There are various processes. I won't go into detail. Some are additive, that is coating, placing a coating on the implant surface like hydroxyapatite coatings. Some are subtractive, that means removing some part of implant like acid etching, sand blasting, titanium plasma sprayed. Now titanium plasma sprayed surface में molten titanium spray करते थे, but that resulted in too much roughness. So it has become very less popular. Nowadays sand blasted and acid etched surfaces are more used by the implant companies. So which implants will you choose now? मैक्रो डिजाइन शेप में कैसा रहेगा वो? रूट फॉर्म स्क्रू शेप, राइट? टेक्सचर में कैसा रहेगा? यस. सो व्हाट इम्प्लांट we prefer these days is root form screw shaped conical implant with rough surface texture, right? तभी हमने इम्प्लांट भी चूज कर लिया, पेशेंट भी असेस कर लिया, अब इम्प्लांट लगाना है. We have to perform the surgery. What we'll need? We'll need instruments, armamentarium. So modern day implant dentistry is driven again by the protocols and armamentarium basically designed by Dr. Per Ingevar Brennemark. His protocols are still followed to a large extent. He used this screw-shaped implant, buried it by placing an osteotomy, creating a hole in the implant bed or bone that is slightly smaller in diameter than the actual diameter of implant, so that he can have a tight fit when he places the implant. So that protocol is still being followed. After this, people have followed, and there are n number of implant companies manufacturing dental implants. One of them is our today's sponsor, Dio Implant, which has a unique kit. We'll be discussing its superiority or advantages over other companies' drilling systems. But basically, his idea was, Brennemark's idea was that you create a small hole and then sequentially start enlarging the size of osteotomy. अगर आपको 4 mm का लगाना है osteotomy, start with 2, 3, 3.5, 4. Sequentially enlarging the size of or diameter of osteotomy. That is called sequential drilling protocol. आप छोटा drill लेते हो, फिर उससे चौड़ा, फिर उससे चौड़ा, फिर final size पे जाते हो. So that kind of protocol was designed by Professor Brennemark and is still being followed. Coming to placement of implant, there are certain general principles that we have to adhere to. One of it is that you have to inform patient about the procedure, about benefits and risk. You have to obtain a written informed consent. Please keep in mind, you all are budding doctors. You will be practicing somewhere in near future. Please keep in mind you have to obtain written informed consent from a patient in view of rapidly expanding medical legal cases for doctors. No, मैंने patient को बताया था, उसने हाँ बोला था, मैंने किया, will not work in court. What will support you is that piece of paper called informed consent. Then you have to choose local anesthetics, and if anxiety is too much, you can go for conscious sedation along with it. Strict sterilization protocol is very important. You have to ask patient to rinse with chlorhexidine mouthwash for 30 seconds to reduce the bacterial load in the oral cavity, so that less amount of bacteria is present in the oral cavity. So lesser bacteria will enter the osteotomy site. क्योंकि क्या हुआ था, अगर ज्यादा बैक्टीरिया होगा तो yes, wound breakdown हो जाएगा, because leukocytes won't be able to kill them and your implant will fail. So sterilization is of utmost importance. Then your surgical technique should be as atraumatic as possible. Avoid overheating the bone. Now what we are doing is we are drilling. So we are creating some kind of friction. When the temperature of bone reaches 40 degrees, 40 degrees is not that high a temperature, it's lukewarm. गर्मी में हमारे यहाँ 42-45 डिग्री हो जाता है, जिसमें हम बाहर जाते हैं. So imagine 40 degree is not very high temperature. But if during the surgical procedure, bone's temperature reaches 40 degrees, then there will be a necrosis of bone. So you have to do atraumatic surgical procedure. You have to use copious amount of irrigation, normal saline, so that the bone doesn't get overheated. Secondly, when you're drilling, जब हम एयर रोटर यूज करते हैं, we do unidirection drilling, right? Crown cutting कर रहे हैं, access opening कर रहे हैं, वहीं जब तक वो dip नहीं आता है pulp chamber का, we don't stop. It's not like that in implant. You have to drill slightly, then pull it out, so that irrigant can flow inside that osteotomy. Then again go, again come. It's called pumping motion. So that kind of drilling technique you have to use. Implant bed has to be prepared in healthy bone. There should not be an active infection present. Ensure good primary stability. Again, because if implant starts moving around inside, when once you have placed, it will not osseointegrate and allow adequate time to heal. That is very important. There is a tendency among implantologists to shorten the treatment time unnecessarily in an heroic attempt to please the patient. So please refrain from that tendency. If your bone requires bone augmentation, or if you have a soft bone, please allow implant to heal. Give it adequate time, 3 months, 4 months, whatever it takes. Because once you invest that 4 months, you are going to give patient a lifetime of healthy tooth. But if you hurry in those initial crucial healing phase, implant might not survive. So it's very important. Now let's see the surgical procedure. There are two types of surgical procedure, 1 stage and 2 stage. Before going into it, let us see what armamentariums we need. We need basic surgical equipments, your run-of-the-mill periosteal elevator, BP handle, needle holders, some artery forceps, tissue forceps, mouth mirror, retractors. Then you need an implant kit. This is an implant kit by Dio Implants. This has 2 compartments. Top one houses the instrument and bottom one houses the wrench. See, in top one, you see a lot of drills and conical instruments. We'll be discussing about this before your hands-on with the kit in hand. But for broader understanding, I would like to tell you that this compartment holds the surgical instrument, osteotomy instrument, that is drill. Then there are 2 other type of instruments. They are called drivers. Screwdriver hota hai. These are implant drivers. Implant driver, this type of driver is used to take implant and place inside the osteotomy. And then there are smaller drivers. This one. These are used to connect accessories to the implant, like tooth to the implants, abutments to the implants. So there are implant driver, or also called fixture driver. When in implantology we say fixture, that means implants. And there are component driver. Component means accessories of implant that will be attached to it to place a tooth. So what we have? We have implant drills or surgical instruments. Then we have implant driver to take implant and tighten it inside the osteotomy. And then we have accessory drivers. Now here we have a ratchet. Right? We were talking about primary stability in the morning. Primary stability कैसे पता चलेगा हमको कि है कि नहीं? आंख से देख के तो नहीं पता चलेगा, आंख से तो सब अच्छा अच्छा ही दिखेगा. So what happens is these ratchets are used. ये ratchet में आप देख रहे हो एक extra flexible arm है. What you do is ये ratchet में ये drivers fit होते हैं. आप इससे tight करते हो. While tightening, if you stretch this flexible arm, it will tell you कि torque कितना है, how rigidly implant has inserted inside it. 10 cm, 20 cm. So these are the ratchets which are used to assess the primary stabilities. इस पे अभी बहुत ज़्यादा focus नहीं करो, because we'll be doing this in the hands-on. What are the components of implants? Implant, body itself or the fixture. Then there is something called cover screw that closes the gap. यहाँ पे implant में hole होता है. इस image में ये triangle है, but it is usually hexagonal. Hex बोलते हैं उसको. ये जो socket है जिसमें चीजें fit होंगे, it's called hex. एक cover screw है. This is used when we are planning to bury the implant inside the mucosa. क्यों? Because ये जो खाली space है जहाँ बाद में हम accessories fit करेंगे, that has to be covered so that tissue doesn't invaginate while healing. And secondly, it eliminates the dead space. Body में dead space कहीं नहीं छोड़ना. खाली जगह नहीं छोड़ना. खाली जगह मतलब बैक्टीरिया का घर. So that this cover screw prevents invagination as well as eliminates the dead space. Then there are prosthetic component. ये abutment होता है जो implant के अंदर fit हो जाता है और उसके ऊपर crown लगता है. So implant or fixture, very good. Implant or fixture, then cover screw, abutment. These are the basic components of implant. There are certain accessories which we'll come to later. So what happens is, in one stage placement, we perform an osteotomy, place the implant and leave some part of implant protruding out from the mucosa. Implant दिखता है बाहर से उसका कुछ part during the healing phase. In stage 2, what we do is we place the implant and bury it inside the mucosa. फिर healing time जो भी 3 महीने 6 महीने whatever was, जब वो हो जाता है तब we expose the implant and then place tooth on top of it. 2 stage, पहले stage में क्या किया, bury कर दिया, osseointegrate होने के लिए छोड़ दिया, बाद में we opened it. Requires 2 surgeries, 2 stage. 1 stage, we left some part of implant protruding during the healing phase, so we did not require to do another surgery to expose the implant. 1 stage. Let's see 2-stage implant placement, how it is done. Are you guys tired? Do you need a break? कितने लोग tired हैं और कितने लोग नहीं?
Yeah, I think you must be tired to grab some water.
चलो.
Fine, we have ordered something and will arrive. So, in the meantime, let us refresh. ठीक है, छोटी छोटी कुछ चीजें जैसे बहुत कुछ बात हुआ मेजरमेंट का एग्जैक्ट और
Any doubts you have, you can ask me meanwhile. We have ordered for some different time shortly. Meanwhile, if you have any doubts, you can say. Any doubts, any
So for single tooth implants, when we do implant placement just after the extraction, and the extraction socket, it's for multi-rooted tooth. I was wondering, sir, if for the multi-rooted tooth, if the extraction socket is very large. So what do we do in that case?
Please sit down. She is asking, in multi-rooted tooth, socket is very large. So what do we do? How do we place implant? Socket वाकई 10 mm by 10 mm कभी मिलता है कभी. What happens is, when you have multi-rooted tooth, you have septum, radicular septum. In 2-rooted or 3-rooted, that is actually a bit advanced implantology, so I don't have any case in this particular slide, but that's not my laptop either. I'll show you. What happens is, there is what you call septum present in the tooth. So we drill into the septum so that when we have placed the implant, it is gripped from 2 or 3 sides, and if we are fortunate enough to have thick septum from all sides. Secondly, we go 2 to 3 mm apical to the socket. Socket यहाँ तक था. We extended implant till here in the bone bed. So it gets that primary stability from the septum and from the apical bone where we have overextended it. And once the bone is formed, socket is healed, it has bone all around to support it. So we try to place it in the center, in the septum. Any other question? Sir, pocket formation around the implant is basically result. It cannot be, nothing can be done while placing, but it is basically result of negligence, lack of oral hygiene, like in the case of periodontitis. So what we can do is we can keep frequent recall visits, assess the patient's compliance, give him additional instruction. If his oral hygiene maintenance is not good enough, you call him frequently. If it is good, then you call him less frequently just to examine and do any intervention required. There's one thing while, doing maintenance in the implant patients, what we use is plastic instruments. We do not use our normal metallic instrument, scaler tip or hand scaler, or even probe for that matter. We are supposed to use plastic instrument because metallic instrument can leave gouging or scratch marks on the implant surface, making it rough. That will attract more plaque accumulation. So this was one thing that came to mind, that when you are doing anything on implant, use plastic instruments. Special plastic ultrasonic scaler tips are available, curates are available, scalers are available, even probes are available. Any other doubt? देखो डाउट कोई भी स्टूपिड नहीं होता है. सो डोंट बी शाई. कुछ भी है मन में, कैसा भी सवाल है, आस्क. Bone volume. This one we are talking about now. See, what happens is, whenever you have, suppose I had this 5 millimeters of bone here. Buccolingually, the thickness of ridge is 5 millimeters. At least, at the very least, I have to leave 1 millimeter bone buccally and 1 millimeter lingually, preferably 1.8, but at least 1 millimeter. So 5 millimeter width था, 1 millimeter इधर का गया, 1 millimeter इधर का गया, बचा कितना? 3 millimeter. So the maximum diameter that I can place in a 5 millimeter wide ridge is 3 millimeters of implant. Getting me? So that I have sufficient buccal or lingual bone. Similarly, mesiodistally also there has to be 1.5 millimeter gap on either side. So if you had 8 millimeters, then you have to place 5 millimeters. But you have to combine both, na? Buccolingually and mesiodistally, उसमें जो छोटा diameter है वो आपको use करना है. बेसिकली आइडिया है कि इम्प्लांट के चारों तरफ 1 mm बक्कोलिंगुअल साइड में और 1.5 mm मेसियोडिस्टल साइड में बोन रहे. एनी अदर डाउट?
Sir, I'm repeating the question. Sir, so you told that within 24 hours in the inflammatory phase, it is decided that whether the implant will be a success or failure. So is it possible without any secondary infection that implant failure can occur after 24 hours or later on?
Yes, it's possible. See, implant fails because of the two reasons. Please sit down. Implant fails because of the two reasons, either of the two. Either there is infection that is, not allowing osseointegration to happen or resorbing all the bone around the implant. Or there is another factor, that is overloading of implant. If there is excessive force on implant because of any reason, maybe because the implant is the only tooth in the quadrant and patient is chewing on it, or maybe because the prosthesis was not designed properly, maybe because implant insertion angle was not good, it was at an angle then being perpendicular or straight, causing what you call deleterious forces, oblique forces or rotational forces around the implant. That can also lead to implant failure. Even osseointegrated implant will become loose in both scenarios. Infection, that is periimplantitis, similar to periodontitis. Implant के होता है periodontitis, तो हम उसको periimplantitis बोलते हैं. Causing bone resorption, leading to implant failure, or abnormal force on implant, be it in the magnitude, be it in the direction. मतलब बहुत ज़्यादा हो या oblique, that can result in implant failure.
Just highlight क्या करने बोला. 24 से जो 48 घंटे बहुत जरूरी है प्लांट के सक्सेस के लिए. इसका मतलब ये था कि we should be very careful in the placement procedure and whatever he had mentioned that should be followed. नहीं तो क्या होगा कि जो इम्प्लांट सक्सेस भी होना है वो भी फेल हो जाएगा. तो आई थिंक जब सर ने कहा था कि 24 से 48 घंटे तुम्हारे इम्प्लांट के सक्सेस को बदल सकता है। तो कहने का मतलब है, जो सर ने पॉइंट उस समय बोला था कि 24 से जब इम्प्लांट प्लेसमेंट के टाइम हमें सेप्सिस का ख्याल रखना, एंटीसेप्टिक प्रोसीजर का, स्टेरलाइजेशन का, टेक्निक का, ड्रिलिंग के टाइम, बोन हीट नहीं होना चाहिए। तो ये सब अगर हम कर देंगे तो अच्छे इम्प्लांट साइट पे भी फेलियर हो जाएगा। ठीक है, तो वही सर कह रहे थे कि 24 से 48 घंटे जो बॉडी का रिस्पॉन्स है, ऑस्टियो इंटीग्रेशन कैसे होगा, तो वो सब इंपॉर्टेंट होता है। तो वो सब इंपॉर्टेंट होता है जो आपका प्लेसमेंट हो रहा है उसके टाइम, अगर आप ये सब सावधानियों को रखेंगे तो इम्प्लांट सक्सेसफुल हो जाएगा। ठीक है, तो वही।
Shall we continue? Continue करें sir. So let's see two-stage implant placement. What happens is, if there is a tooth missing and we have planned for two-stage, there are two types of incision that we can use. One is crestal incision, given at the center at the crest of the alveolar bone on the mucosa to reflect one buccal and one lingual flap. Or there is something called remote incision. In remote incision, we give a horizontal incision 2 millimeters, 1 to 2 millimeters apical to mucogingival junction. अभी ये नई चीज क्या है म्यूकोजिंजिवल जंक्शन? जहां पे ओरल म्यूकोसा और अटैच जिंजाइवा का जंक्शन होता है, मतलब बेसिकली पॉइंट जहां पर से टिश्यू मोबाइल हो जाता है, उससे 1 से 2 मिलीमीटर नीचे we give a horizontal incision like this and then reflect a flap. This type of incision is recommended when you are planning for any regenerative procedure, bone augmentation procedure, bone graft करना है हमको, GTR membrane लगाना है. So this type of incision is preferred because it eliminates the chance of exposure of your regenerative material. यहाँ पर कुछ भी नहीं है, complete undisturbed mucosa will be covering. Incision हमारा यहाँ है, तो even कुछ भी हो तो we have eliminated chance कि हमारा जो bone graft अंदर है that gets exposed. So a crestal incision and a remote incision. Crestal incision is normally used. Remote incision is preferred in case of regenerative procedures. Now what we do after elevation of the flap, we mark our osteotomy site. हमको कहाँ पे osteotomy करना है, कहाँ पे करना है? See, it should be in the dead center, mesiodistally and buccolingually, at the center of the alveolar ridge. That is the best point to place the root, right? Place the implant. So we mark it with a round burr like this. We drill a small hole or a ditch penetrating the cortical bone. Once we have established the point where we are going to place our implant, we use the first drill or the smallest diameter drill, call it pilot drill, to create osteotomy of desired length. जैसे 10 मिलीमीटर का डालना है तो ये 2 मिलीमीटर की ड्रिल से 10 मिलीमीटर लंबा deep osteotomy will do. And then we'll use sequential drill 2.2, 2.8, 3.5, whatever the sequence available with particular implant companies to reach a desired point. Now at this point, we must know that when we are placing implant, we create osteotomy 0.5 to 0.8 millimeters smaller than actual diameter of implant. So if you are going to place 4 millimeter implant, what will be the size of final osteotomy? .2 to 3.5, right? 0.5 to 0.8 millimeter shorter. Why? Because when we drill a shorter hole and place a larger screw, we get more stability, primary stability. So this is the final osteotomy prepared after sequential drilling, and this is implant placed. Once the implant is placed, the whole of the implant is covered with cover screw. You can make out in the radiograph also there is another entity inside the implant's body. Can you make out? Is it clear enough here? Can you see there is screw inside it? It's called cover screw. Once we have placed the implant, placed the cover screw, checked it with the radiograph that we are away from all vital structure, inferior ulnar nerve, adjacent tooth, root, direction of implant is good enough, parallel to the adjacent roots. We close it with interrupted sutures. We leave it to heal for 3 to 4 months in the mandible and 4 to 6 months in the maxilla. Once the healing has occurred, we expose the implant. We can give a crestal incision and expose it similarly, but what I am showing you here is called punch incision. In this, you give a circular incision via an instrument called punch. Punch biopsy देखी किसी ने? Similar to that, there is a drill that is used. You expose the implant and place a healing cap or gingival former. This gives gingiva the contour. हमने incision दिया, हमको wait करना है उसके heal होने का. So we have placed a healing cap. It will give gingival collar, make a gingival collar or give gingiva a contour around it. Once the healing has occurred, you get a nice gingival collar like this. Can you appreciate? Round gingival collar. Then you place abutment and place tooth and all. Now, one stage implant, what we do is we give an incision, place the implant, and leave gingival former. The gingival former that we placed in the second stage. We leave it and close the mucosa. Then there are certain implants that are called one-piece implants. ये तो two-piece था. Implant अंदर था, ऊपर का सामान अलग था जो screw से tight कर रहे. There are certain implants that are one-piece implants meant for one-stage surgery. उनमें उनका ऊपर का part जो abutment होता है, that is already fused with the implant. So that will be protruding out. You close it and then you wait for healing. Once the healing is complete, you place the prosthesis. Now, how do we place the prosthesis? क्या कोई difference होता है implant prosthesis और normal prosthesis में, इस crown में और उस crown में? Impression में कोई difference होता है क्या? Let's have a look. There are certain implant components that are used in prosthesis. They are, first is implant body that we all know. Abutment, वो जो ऊपर screw होता है. Suprastructures, that is the crown or what you call denture or whatever type of prosthesis you are fabricating. Then there are accessories. Two types of accessories. One is surgical accessory, healing screw और gingival former, जो हमने देखा अभी, याद है ना? Then prosthetic accessories like impression post, ये नई चीज है, इस पे अभी तक हमने डिस्कस नहीं किया. There is something called impression post and then there is something called implant analog. इसके बारे में हम अभी बात करेंगे. हमने देखा सुपरास्ट्रक्चर, क्राउन, डेंचर, whatever, abutment, implant. हमने देखा gingival former और healing cap. Now, why is that implant impression has so many components? इतना ये abutment चाहिए, analog चाहिए, ये चाहिए, क्यों चाहिए भाई? सीधे सीधे क्यों नहीं ले लेते हम? Because we have to take implant impression in 3-dimensional accuracy. उसका buccolingual angle, mesiodistal angle, उसका depth inside the gingiva, all has to be recorded very precisely to fabricate a long-lasting restoration. There are two methods. One is direct or open tray, and second is closed tray. We are seeing the closed tray first. Now we had talked about जो दो चीजें नहीं बताई अभी तक, वो क्या था? Impression coping or implant analog. So here is impression coping. ये दिख रहा है? Closed tray coping आती है एक, open tray coping दूसरी आती है. दोनों अलग अलग है. There are two types of coping. Impression coping. One used for closed tray impression called closed tray coping. One open tray impression technique called open tray coping. Now what we do is this gets attached to this what you call implant like an abutment. Now, on top of it, you make an impression using rubber-based impression material, light body and heavy body. Once you have taken the impression, the coping is unscrewed and placed inside the impression. On top of it, an implant analog will be placed. Implant analog is what dummy implant समझो. इसके ऊपर वो ये जो स्क्रू दिख रहा है इसके ऊपर डमी इम्प्लांट लगेगा, फिर कास्ट पोर होगा. वो सब कुछ कास्ट में आ जाएगा. जब इसके ऊपर पोर करेंगे प्लास्टर के साथ ये सब मेटल का जो भी घुसाया हुआ है हमने सब कास्ट में आ जाएगा. एंड इट विल रिप्लिकेट द डेप्थ जिंजाइवा के कितने नीचे है आएगा, उसका एंगल क्या है, सेम रिकॉर्ड. सो इट विल रिप्लिकेट इम्प्लांट्स पोजिशन इन ऑल 3 dimensions. Advantage of this technique is it is very useful in inter-arch space. जो close tray abutment होता है, coping होता है, बहुत छोटा होता है लेंथ में, तो माउथ ओपनिंग कम है, then also you can fit it because its length is less. The gag patients, क्योंकि ये प्रोसीजर बहुत जल्दी खत्म हो जाता है, short procedure है, so it's helpful in patients with gag reflex. Posterior area जहाँ पे access difficult है, जहाँ पे आपको implant के अंदर attachment करने के लिए भी नहीं दिख रहा है, वहां पे ये टेक्निक प्रेफर की जाती है बिकॉज देयर आर लेस अटैचमेंट्स एंड लेस मैनिपुलेशन इनसाइड द ओरल कैविटी. इट्स टाइम सेविंग, मोर कंफर्टेबल, शॉर्ट है इसलिए टाइम सेविंग भी है, कंफर्टेबल भी है, इजी टू मैनिपुलेट, एंड इसके लिए कोई स्पेशल प्रिपरेशन की जरूरत नहीं पड़ती जो ओपन ट्रे के लिए पड़ती है. हम देखने वाले हैं अभी. नाउ लेट्स कम टू द ओपन ट्रे. इन ओपन ट्रे we get impression copings that are called open tray copings. Now these copings will protrude out. Closed tray में क्या था, हमने ये coping लगाई, impression निकाला, फिर coping को खोला और impression में घुसाया. There are chances of error in that. हो सकता है आप उसको properly fit नहीं कर पाओ impression के छेद में, हो सकता है थोड़ा और अंदर जाना था न जाए, हो सकता है आप थोड़ा टेढ़ा fit करो. There are chances of error. In open tray, what happens is these coping protrude out. ये वैक्स से ढका हुआ है, इसके नीचे coping है. ये वैक्स निकाल के वो स्क्रू खोल के when we lift the impression, coping comes out with the impression like this. वो मुंह में नहीं रहता, वो impression के साथ बाहर आ जाता. फिर इसके वो आप implant analog fit कर दो इसके ऊपर से, and you get 3-dimensional replication of your implant positions. Multiple implants में prefer किया जाता है ये. Now, in some cases, there are chances that when you are taking the coping out and fixing implant analog, that implants may move little bit here and there. 1 or 2 degrees movement can also make significant difference, right? So what we do is we splint these copings together. अभी एक acrylic का वो बार बना दिया, उसको जोड़ दिया. Now there is no chance that they'll move in any direction. जैसा घुसाया था वैसा ही निकलेगा. Then you take an impression on top of it and take out the coping along with the impression. So this splinting, it's called jig formation. Implantology के terms में ये splinting is called jig formation. So this jig prevents distortion or eliminates the chance of distortion in implant angulation while recording impressions. Then there are digital impression, CAD CAM techniques के through. CAD क्या होता है? Computer assisted designing. CAM. So ये 2 अलग-अलग चीजें हैं, designing and manufacturing. What we do in this is we use, do I have a picture of it? Yes. We use scanner, intraoral scanner like this. We scan the oral cavity to get and scan data like this. It is scanned everything, implant, gingiva, सब कुछ scan हो गया. Now this scanner's data is transferred into software to create a virtual model which is precise to the millimeters. This virtual model formation, जहाँ तक ये virtual model formation होता है सॉफ्टवेयर तक, that is CAD. डिजाइन कर लिया हमने, हमको क्या चाहिए. इसके ऊपर एक क्राउन डिजाइन होएगा वर्चुअली. नेक्स्ट कम्स कैम मैन्युफैक्चरिंग. अभी ये सारा डाटा 3D प्रिंटर में ट्रांसफर होता है. उसका स्पेसिफिक्स डिजाइन, उसमें कितना विड्थ होएगा, किस पॉइंट पे कैसा कंटूर होएगा, everything is transferred into 3D printer and a restoration is built like this. That restoration is directly placed into the patient's mouth. No impression, no cast pouring, very well accepted by the patients, time saving, hassle free procedure. But it requires significant amount of inventory. You need a scanner, you need a 3D printer, you need software. That is all very expensive, but it is slowly becoming popularized in dentistry as impression-free dentistry. And with the increased use, the cost of such things will come down. So keep in mind, there will be a time in dentistry where you will be no longer using alginate or addition or condensation silicone. You'll be using a scanner and immediately giving a patient with a crown. In foreign countries, more advanced countries, this is the trend. Patient का scan होता है, then they make him sit in the lounge. 1-2 घंटे आप लाउंज में बैठो, मैगजीन पढ़ो, टीवी देखो. फॉरेन में तो बियर भी दे देते वो लोग. So you enjoy. After that, once the restoration is made from a 3D printer, fit करते हैं and then they send him. Imagine 2 घंटे में सब कुछ. So that is the recent advancements. Now हमने देखा बढ़िया, अभी सब कुछ देखा. सिनेरियो वाज ऑल हंकी डोरी. अच्छा बोन था, बढ़िया ऑस्टियोटॉमी किया, हम इम्प्लांट लगा दिए, दांत भी लगा दिए. एवरीथिंग वाज हंकी डोरी. बट देयर विल बी सिनेरियोज वेयर देयर विल बी डेफिशिएंट बोन. Bone volume will not be sufficient. What to do in such situations? The deficiency in bone can be caused either in terms of height or width, as we have seen previously. So reduced height or reduced width will hinder you from placing implant in proper position or placing an adequate diameter of implant. So in such cases, what do we do? To deal with any problem, first we need to categorize the problem. Right? Categorize karoge tab to solution खोजोगे. So this is a classification. Again the same one, class 1, reduced width, sufficient height, Siebert's classification it is. Class 2, reduced height, sufficient width. Class 3, neither height nor width. So what is the solution of this problem? Now before, there is a saying, no, prevention is always better than the cure. So before moving it into the solution, let's see how to avoid these scenarios. These scenarios can be avoided by preservation of extraction socket. Tooth nikala, उस socket को अगर हमने preserve कर लिया, we'll have sufficient amount of bone volume in the future. How do we do it? First is use less traumatic extraction techniques. There are some instrument, very nice instrument called periotomes. They are thin bladed instruments that are pushed in between the tooth and the bone in the periodontal ligament space. And periodontal ligament is cut out. They are available manual. There are piezosurgical periotomes also available. So you cut the periodontal ligament out and take the tooth. It causes less trauma to the neighboring bone, resulting in less post-extraction resorption. Second is socket grafting. Placing a bone graft and a GTR membrane in the socket can reduce the amount of bone that will be lost during the healing. Then, this point is most important. I don't know about you people, but when I was in 3rd year, हमारे को सिखाया कि दांत निकाला, फिर बढ़िया दबा दो सॉकेट. और इसके साथ ना लेजेंड्स एसोसिएट हो गए, मिथ्स. देयर आर मिथ्स. पीपल से इट विल प्रिवेंट ब्लीडिंग. कैसे? देयर इज स्टिल बिग गैप इवन विद पिंच द सॉकेट. दिस ट्रेंड वाज स्टार्टेड टू क्रिएट रेसिडुअल रिज विदाउट undercuts to fabricate removable partial denture. Aim of that pinching is to eliminate any undercuts in the ridge. ताकि आप बाद में अगर removable prosthesis बना रहे हो तो it will be easier to fabricate. But we have almost discarded removable prosthesis. That era is behind us, far behind us. So that should not be done. What we are doing here is we are reducing the bone volume. People, so enthusiastically compress the socket that sometimes they fracture the labial cortical plate. And labial cortical plate, believe me, is gold for implantologists. मिलता नहीं है. जहां दिखता है ना implantologist का मन नाचने लगता है. वो क्या आजकल आ रहा है ना, वो नितेश शेट्टी आता है ना, देखते हो तुम लोग, तागुड़दुम्बा. इम्प्लांटोलॉजिस्ट के मन में वही होता है लेबियल प्लेट देख के. है अच्छी तो खुश. सो मेक इट अ पॉइंट, take a oath with me from today onwards, whenever you extract a socket, you will not compress it. It does not help. It causes harm. Then there is another method of saving what you call socket tissue is placing implant immediately. This is a case. Patient had a post and core which failed and it was continuously failing. The tissue was not sound, tooth was indicated for extraction. We removed it using periotomes. Can you see there was very minimal flap elevation? Can you make out the socket walls? And can you see a small hole here? That is the point where we had created an osteotomy, apical, someone was asking me. Apical to the extraction socket. We place the implant. This is a ratchet I was talking about. This here are the number, some random numbers are written. If you can see 15, 35, 50. This flexible arm, when the implant is tightened, when we pull this flexible arm, at some point it stops. That gives us torque value. This is giving us insertion torque value. It's very important. You have to achieve around 20 NCM of torque for good stability. And if you want to place implant, so where will be? हाँ, ये आपको इंसर्शन टॉर्क दिखाता है, ये रैचेट. If you want to place tooth immediately after placing implant, मैंने अभी implant लगाया, मेरे को दांत लगाना है, then you have to have torque value of 35 NCM or above. So implant was placed. Now this will result in prevention of resorption of socket walls, especially in anteriors. In anteriors, labial plate is paper thin, 0.5 millimeter thickness. It will resorb regardless whatever you do. But if you place immediate implant, you have a chance of saving it. Provisional prosthesis bhi de diya because torque was good, around 45 NCM torque was there. So we loaded it immediately. Now ये सब नहीं किया, अगर हमने preserve नहीं कर पाए socket and bone loss हुआ, then we go for bone augmentation procedure. One is guided bone regeneration, where you place bone graft and cover it off with the membrane. Can anyone tell me what is the use of that membrane? क्यों membrane लगाते हैं? Graft तो लगाया ना, और क्यों extra लगाते? Anybody, any wild guess will also do. Very good. See, what happens is wherever there is an empty space, there is race between cells. Now, सब में competition होता है कि ये plot हमको चाहिए. Now, thing is, we want osteoblasts and fibroblasts and all the connective tissue cells to occupy the space. Problem is epithelial tissue has a very high proliferative index. No. So if there is a race, epithelial tissue will win. And what will happen? There will be invagination of epithelial tissue in that region. और epithelium घुस गया तो bone के लिए जगह ही नहीं. So that is why we place this membrane to prevent epithelial invagination as well as some fibroblast invagination. and give ample amount of time to our lazy fellow osteoblast कि वो अपना धीरे धीरे आए और वो जगह को ऑक्यूपाई करके बोन बना ले. Got it? That is the purpose of this. So we place bone graft, we place membrane, and we close it. In some cases, there is not, when there are defects are not contained, walls नहीं है, bone graft powder टिकेगा नहीं. ऐसे cases में what we do is we use block bone. Like this, you see there is deficiency in buccal wall. So we, okay, this is not the case. This is the case. You see deficiency in what you call height. ऐसा आर्च शेप डिफेक्ट है, उसमें बोन ग्राफ्ट टिकेगा नहीं. इसमें कहाँ पे बोन ग्राफ्ट का पाउडर अपन लगाएंगे? नहीं लगा सकते. सो व्हाट वी डू इज, ये भी GBR है, कहाँ गया? ये है सिमिलर आर्च शेप डिफेक्ट. What we do is we take bone block from the ramus or symphysis or any other region, do some corticotomy to initiate healing. एक ऐसा open wound create करते हैं, corticotomy punch करते हैं, and then place the block and secure it with the screw. Now, if you can compare post healing, see this was the depth of this arc. Post healing depth has reduced to manageable proportions. So that is, now we can remove the retaining screw from here and place an implant. Then in maxilla, sinus हमारा पुराना दुश्मन है. Sinus will keep expanding and eating off all the residual alveolar ridge. So what we do is when there is deficient height of the bone in posteriors, we go for a sinus lift procedure. There are two types of sinus lift procedure: indirect sinus lift and direct sinus lift. Let us see what is direct sinus lift first. This is a case, very less amount of bone available. The direct sinus lift is preferred when there is less than 4 mm height of residual, what you call bone present. So we open a window here, bony window. The grayish thing that you see is Schneiderian membrane or lining of the sinus cavity, sinus membrane. Lift it, place bone graft, and then close the window and close the defect. Once it heals, you'll see this kind of bone formation and site will be ready for placement of implant. There is another procedure, indirect sinus lift, where there is more than 4 mm of residual bone present, or you want bone elevation up to 4 mm. 4 mm से ज़्यादा bone elevation नहीं मिलेगा इसमें. In this, what we do, we drill osteotomy, stop 1 mm short of the sinus floor, then we push osteotomes to fracture it and elevate the membrane. And then through this hole, we keep pushing bone graft. Around 5 to 1 cc of bone graft is usually pushed inside the sinus and then followed by placement of implants. This is a case. Look at the bone height, more than 4 mm approximately. So osteotomy was prepared, membrane elevation and pushing of bone graft. You can see some fragments of bone grafts here. Can you see? Can you make out this fragment? Implant is placed. This is post healing. You can see nice amount of bone formed around the implant site. Can you make out? So these are the procedures that implant was placed, restored. So these are the procedures that help us deal with problems of insufficient alveolar bone. So today we have learned that we need to diagnose a case properly, look and eliminate or avoid potential medical and intraoral problem, that is diseases, or there is space present or not, whether there is bone present or not. Then we learned that there is something called a implant kit, which has 3 types of components. What were those components? Surgical drill. अब इस रो से मैं नहीं सुनूंगा, पीछे वाले बताएंगे. अब तो बोल दो. Implant drills. Come on, speak with me, yaar. Come on. Implant drills, fixture drivers, accessory drivers. Drills are used to create a hole in the bone. Fixture drivers are used to tighten the implant into the cavity. And accessory drivers are used to attach accessories to the implant. There are two types of implant procedure that we learned. Placement procedure, one stage and two stage. Then there are two types of impression techniques, closed tray and open tray. And what I didn't include in this presentation because I was afraid that we might not have sufficient time, there are two types of crowns also. One is called cement retained crown. You know, cement retained crowns are the crowns that are placed in the implant the way we place normal crowns, cemented on top of abutment. They are done when we have more than 5 mm of height available. But if height is less than 5 mm or 5 mm or less, we go for screw retained crown. In this what happens, abutment याद है अपने ऊपर लगता था. इस abutment के ऊपर ही crown build होता है. And it is screwed directly inside the implant cavity, hex. So दो types of crown होते हैं. Implant cement retained crown, जो cement किए जाते हैं when we have more than sufficient of height present. But if we have less height, we prefer screw retained crowns, which are screwed into the implant. Now, any doubts from this session? No doubts? None at all?
Yes, you are. He has told different procedures, one stage, two stage, immediate loading, delayed loading. So why there are so many cases? You have any doubt? Is it clear with you all? There is single stage. He told all about two stage. There is immediate implant. Why? What are all these? Why there are so many? Anyone?
What is the need
What
of
is the need? Just to improve the increase the number of procedures, increase the number of methods, or is there any need? Certain indication.
I'll answer that regardless. I hope सर ने एक क्वेरी तो इग्नाइट की होगी तुम्हारे मन में सवाल तो आ रहा होगा क्यों?
Why?
See what happened was when implantology initially started, एकदम स्टोरी है ये, बेड टाइम स्टोरी जैसे सुनाते वैसे मैं आपको बताता हूँ. जब implantology स्टार्ट हुआ, people were very scared. लोगों को डर था, implantologists को डर था कि if implant is exposed during healing, उसका मूवमेंट होएगा और osseointegration नहीं होएगा. That was the reason that Brenemark or initial implantologists preferred two stage. लगाओ, डुबा दो, keep it submerged below, even keep it 1 millimeter below the crest of alveolar bone, so that no pressure from the provisional RPD also can cause any movement. Later on, we started learning that it is not that crucial. If you have good amount of primary stability, the implant will osseointegrate anyhow. So we dared and we reduced it to one stage surgery. Advantage being in two stage surgery, we had to perform two surgical procedures. Simple. In one stage surgery, we perform only one surgical procedure. Secondly, the soft tissue around implant, the mucogingival management is better with one stage surgery. As the time passed, more research flew in. Then implant was not even getting accepted because 6 महीने साल भर आपको रुकना पड़ेगा. क्या होता था? You extract the tooth. 6 महीने आप वेट करो कि वो हील होएगा. Socket heal हो गया, then you place implant, again wait for 4 to 6 months. then expose it, wait for 2 weeks, then take impression, दांत बनते थे 1 महीना. So this process from removal of tooth to placement of tooth ranged up to 1 year. Then implantologists started shortening this treatment time as our understanding of the what you call stability and osseointegration grew, advancement in the implant surfaces made, we started shortening this time. Then ultimately we devised an immediate loading protocol. Immediate loading protocol is whenever you place an implant, if you have sufficient amount of torque, there's a debate, some say 20 NCM minimum, some say 35 NCM. I prefer 35 NCM. If you have 35 NCM of insertion torque, itna tight agar gaya hai wo bone mein, then you can load it immediately. दांत तुरंत लगा सकते हो. So this understanding led to development of immediate loading protocol from one stage surgery to immediate. In between there are different protocols, early loading, प्रोविजनल लोडिंग 2 हफ्ते के बाद लगाया तो उसको अर्ली लोडिंग क्या है. प्लेसमेंट के भी प्रोटोकॉल आ गए, पूरा हील होने का वेट नहीं करना है, इमीडिएट प्लेसमेंट कर दो, अर्ली प्लेसमेंट कर दो, दांत निकालने के 1 महीने के अंदर प्लेस कर दो. सो दीज ऑल अटेम्प्ट्स वर मेड टू शॉर्टन द ट्रीटमेंट टाइम एंड इंक्रीज पेशेंट कंफर्ट. And all this changes or shortening in treatment time was possible because of continued research and constant development in understanding of the physiological process as well as development in the implant designs and morphologies. So that is why we have so many protocols. क्योंकि हम फर्स्ट स्टेप से चले थे, अभी हम कहीं ऊपर पहुंच गए, तो रास्ते में जो कुछ भी चेंज हम कर सकते थे हम करते गए और नए प्रोटोकॉल्स बनते गए. This simplest explanation I can give. Any other doubt? See, there are हर प्रोटोकॉल का अपना इंडिकेशन. You cannot use immediate loading anywhere. But if followed properly, all the protocols have success rate in higher 90s. Immediate loading has success rate 95%, 95 to 97%. But अगर आपके पास D4 बोन है, सॉफ्ट बोन है, जिसमें आपको इनिशियल स्टेबिलिटी मिल ही नहीं रही, टॉर्क नहीं मिल रहा, अगर आप उसमें इमीडिएट लोडिंग करोगे, व्हाट विल हैपन? इम्प्लांट विल फॉल ऑफ. उसमें आपको ऑसियो इंटीग्रेशन होने तक रुकना पड़ेगा, सो दैट देयर इज अ रिजिड कनेक्शन. सो इफ यू अप्लाई द प्रोटोकॉल्स प्रॉपरली, जहां जो रिक्वायरमेंट्स हैं वो फुलफिल हो रही है. फॉर एग्जाम्पल इमीडिएट लोडिंग के लिए टॉर्क होना चाहिए, जैसा आपको बताया. अगर वो टॉर्क नहीं है और आपने किया तो फेल होएगा. अगर वो टॉर्क है, आपके पास उतना स्टेबिलिटी है इम्प्लांट का, उतना टाइट फिक्स हुआ है वो, तो आप उस पर दांत लगाइए, यू विल हैव गुड सक्सेस रेट. Thank you all for your patient hearing. I have displayed my WhatsApp number. You can search me on Facebook, Dr. Vaibhav Tiwari. If you have any queries, anything you want to know from me, you can contact me after the lectures also. I'll hand over the dais to Dr. Vishnupati sir.
So, fine, it was a very good presentation from Dr. Vaibhav Tiwari, well paced. I hope the young minds, they have intercepted this transmission well, and it was specially meant for you people. Fine, the very basics, how implant is. और जब भी कुछ नया शुरू करोगे ना, तो मुश्किलें होती हैं, डाउट होता है. जैसे पूछ रहे हो इम्प्लांट कैसे सक्सेस होता है, सोचो एक फर्म टूथ जब तुमने निकाला टूट गया, फिर मुश्किल से निकला, किसी से हेल्प लिया. तो कोई भी नया चीज ऐसे ही होता है. फाइन, व्हेन यू एंटर इट यू विल हैव सम डिफिकल्टीज, यू माइट नीड सम हेल्प. Fine, online videos are there, experts are there, you can call anyone, they are all so generous, they will always come up and help if you have landed in any difficulty. Fine, so you just have to enter into it and start. There are a lot of people who will help. And now I'll just request that you please be seated. Fine, there is an important announcement also that he is here for today and tomorrow. So if you want to personally interact, ask some doubts, fine, regarding choosing of implant system, how do we go ahead, whatever In the lunch time also you can interact. In the hands-on workshop also you can interact. That is why tomorrow we have a live surgery. Fine, that surgery will be displayed here on the screen with a hands-on mic. He will be performing, he will be explaining how incision is given, how drilling is being done. And we will, as sir has told, if you have that sufficient torque, we will do the immediate loading also. Tomorrow only a temporary prosthesis will be placed on the implant, hopefully. Fine. So if everything goes off well, what you have learned today, tomorrow you will see it in the practical steps also. So tomorrow from, we will start our preparations by 9 a.m., but by 10 we will definitely start the surgery. So as today you all have followed the Indian Standard Time and you have come at 10, 10:15, 10:20, please don't do that tomorrow because you will miss the surgery. Fine, we are very particular with time. That is why today also, whosoever was present, we started at 10. So tomorrow also the surgery will begin at 10, I am telling you. Fine, so please come here, take your seats at 9:30. In between also we can interact with the surgeon. Fine, when he is placing the implant from here, you can talk, you can clear your doubts. Fine, there will be a two-way interaction system. So please come and enjoy the learning experience and get a first-hand knowledge about the practical experience also. Now, one of our sponsors today for the event, they want some slides to be presented. So we'll just go through their presentation once. Fine. So they are our auxiliaries and we have to know what their products are or when to prescribe. See one of this polydent you all must be using in the our department also, denture adhesive. Fine. So this is a denture adhesive, fine, in a paste form, and it has this indication. It gives a better adaptation with the denture to begin. Fine, there are no treatment guidelines as of yet now, but this is very good adaptive process for the denture wearing patients. And you can use this in your jaw relations also, trial also, fine. So denture adhesive is one thing which should be used, and Polydent is coming, it has come up with a denture adhesive. It is in the market for so many years. So I think you all are aware, you have read in the theory how denture adhesive works, fine. So this is just an explanation of all this. So no need to go into the detail, but you should know when it is to be used, how it is to be used. So you should tell the patient when to use, how to use. But I feel this denture adhesive is one good adaptive process for any healthy denture wearing patient, so that his initial trouble days are decreased by the use of this denture adhesive. It will reduce the gingival irritation from trapped food particles, because it will hold the denture, so food and all the particles are not going to go inside. So it will prevent all those things. Fine, so this is all about it. Now next, fine, we have lunch for the faculty members, staff, delegates, interns. Fine. Who are, क्या है? ठीक है, interns who are non-participants and non-volunteers and final years who are not participating, they can first proceed for refreshment. Third year, second years also.
All the students.
All the students.
Those who are non-participants proceed for outside.
ये किसका है? मेरा.
Interns, non-participant, non-volunteer. Final year, non-participants. First year, second year, third year. Please proceed. प्लीज प्रोसीड। बाहर में रिफ्रेशमेंट आप लोग के लिए है। बाहर में रिफ्रेशमेंट आप लोग के लिए है, रिफ्रेशमेंट लेकर चले जाएंगे आप लोग।
सर ये ऑन नहीं है. सर इसका फुट होएगा. थैंक यू. ठीक है प्रणव जी, ये 410 है नहीं, 410 है ना सारे. चलो आर वी रेडी? सब सेट है अपना. आप लोग सारे इंटर्न्स हो यहाँ पे? फाइनल ईयर भी? कौन कौन फाइनल ईयर है? अरे वाह. और इंटर्न्स? फाइनल ईयर्स आर आउट नंबरिंग इंटर्न्स क्या? दैट्स गुड, दैट्स गुड. हाँ, 50-50 रेशियो, ऑलमोस्ट 60-40. Who is our camera person? Camera person? Camera, who will be operating? I'll need a close-up of this. Yeah, I am on the screen. Chalo, let us start the hands-on. First, we'll have a look at the drill. As we were discussing during the lecture, there are three types of components. First are drills, which are used to do osteotomy. Now, this is a standard DOUF surgical kit, which has a starter drill, a lancet drill. If someone can focus on my hand, this drill has a very sharp tip. Is it visible in that screen? So this is a tip, sharp pointed tip. This advantage of this lancet drill is that when you are doing a drilling, if you are planning to do a drill or implant and you start with wider diameter tips, what will happen is when you place the drill here and it is rotating, so it might slip. But because of this very sharp tip, this lancet drill does not slip. So this will be used to mark the osteotomy site. Then there are 2 mm drills. 2 mm drill is the first drill that we are going to use to perform osteotomy. Now this drill has certain stoppers. If you can see here, I'll wait for that. It has certain stoppers of different lengths. Like suppose this is 8.5 mm stopper. I place it on 2 mm drill. Like this. Now what will happen is the whatever part that is outside the stopper has length of 8.5 mm. So I don't have to worry whether I'll over drill it or under drill it. I'll just place the stopper and start drilling. Stopper will stop me when I have reached desired length. So similarly, we have lengths of 8.5, 10, 11.5 and 13 in DO system. So accordingly, stoppers are there. Then when we look at the kit, the diameter, these are different. Each row represents a different diameter. The first row is for 3 mm and 3.3 mm diameter implant. Corresponding lengths are there. The first drill is 8.5 mm. Its entire length is 8.5 mm. So you don't have to worry while placing that how much you have gone. If there is any anatomical structure and you over drill it, you might damage it. But with this self-stopper drills, you do not have to worry. Then there is different, the shape of drill is different. It has blades protruding in a plus manner. Now what happens is when you are drilling, my experience is that some amount of the bone always gets trapped in between this blade. Some amount of bone while you are doing osteotomy gets trapped in between these blades. You can procure it, collect it and use it as a bone graft if needed. Small defects can be easily filled with that much of bone that we get from these drills. So 3 mm, then next line corresponds to diameter of 3.8 mm. Next line corresponds to 4 mm. Next corresponds to 4.5 and 5. Each line corresponds to one diameter. And each drill in this line, suppose if I say 3 mm diameter line, if I picked, first drill is 8.5. If you are going to use 8.5 mm length implant, just put this drill and you are done. Similarly, there is 10 mm drill, there is 11.5, there is 13 mm drill. So for each corresponding implant size, there is a drill present. Use pilot drill and then use corresponding drills in sequential manner. So that makes it very easy to do osteotomy. It prevents a lot of cumbersome thing when you have to measure the length. You have to constantly monitor on the marking. That and all is avoided. And there is no chance of over drilling with these drills. Then in the last line, there is a different kind of drill called cortical punch. We were discussing about D1 bone, where there is lot of cortical bone. You cannot compress already compacted bone. If you over compress, there will be necrosis or microfractures. So what we do with these drills is, if we have a dense cortical bone, lot of dense cortical bone like in D1 category. We use this to widen the diameter at the cortical bone region only. So जहाँ पे हार्ड है बोन वहाँ पे आपने डायमीटर बढ़ा दिया कॉर्टिकल पंच से या प्रोफाइल ड्रिल बोलते हैं डीओ कॉल्स इट प्रोफाइल ड्रिल सर्टेन अदर सिस्टम्स आल्सो हैव इट दे कॉल इट कॉर्टिकल पंच सो आपने हार्ड बोन का डायमीटर बढ़ा दिया सॉफ्ट बोन के अंदर थोड़ा छोटा रखा है तो एंड रिजल्ट होगा कि आपका इम्प्लांट हार्ड और सॉफ्ट बोन में स्नगली फिट होएगा विदाउट ओवर कंप्रेसिंग द बोन सो दीज आर द ड्रिल्स that are present starting with the lancet drill to mark the osteotomy site, then use the 2 millimeter drill till the desired depth. जैसे हम यहाँ पे 4/10 का implant place कर रहे हैं, तो we'll drill till 10 mm length. Then you'll take 10 mm drill from the different diameters, starting from smaller till the desired diameter to create osteotomy site corresponding to 4 mm by 10 mm, 4 mm diameter and 10 mm long implant. Once we have used these drills, there are drivers, fixture drivers. Fixture means implant. These drivers will be used to pick up the implant from its packaging. Like this. And then place it in the osteotomy. Following driver, if you look at the second compartment, this thing comes off. In second compartment, you have ratchet. This ratchet is used to, this is not the ratchet for this one. This ratchet will be used to tighten the implant in the osteotomy site. Now I'll just show you like this. Getting me? Like this will be tightening. I'll show you everything. I'm just showing you the components of the drill. So these are the fixture driver. Now there are two kinds of fixture driver in this. One is to be used with endomotor and other is manual, just what I show. This one will be used with endomotor and this one will be used manually. We can use endomotor handpiece to place implant initially, but final positioning or tightening of implant is always done manually because you have more control over it and you can constantly measure the amount of torque, insertion torque that we are getting. Then there are smaller drivers. This is called what you call screwdrivers for component or accessories. Accessory driver. You can use this to X drivers. You can use this to place cover screws and abutments. So these are the components of drill, and plus if you see the inner compartment, they have given a metallic tray. This can be used to keep your components in one place so that you don't have to struggle finding it, because implant components are very small, so you have to keep them in one place so that you don't miss out. कोई कॉटन के नीचे ना दब जाए या किसी इंस्ट्रूमेंट के नीचे ना दब जाए और आपको खोजते रहना पड़ जाए. So let us start. This is a physio dispenser that will be used to place implant. Now, why do we need a physio dispenser to place? Why can't we place it with micromotor? The thing is that physio dispenser delivers good amount of torque. When we use an air rotor or a micromotor, what happens is that it cuts the tissue by grinding it. Getting me? घिस घिस के काटता है. Now, grinding generates lots of friction and friction generates heat. So that can damage the bone. What happens with the physio dispenser is that it creates a lot of torque. Power बहुत है उसमें. Horse power ज़्यादा है उसमें. Getting me? बाइक वालों को पता होगा, horse power ज़्यादा है. So what happens is these drills, they do not grind the bone. They bite on the bone and chop it off. This way there is less friction, and for biting and chopping it off, you need high power. So we use physio dispenser. Additionally, this provides constant irrigation. From this tip, there will be water flowing. We have not kept it for demo here because it will be very difficult to manage lot of saline. But constantly saline keeps on flowing. So that constant irrigation helps in keep the bone cool. So this is the basic two. These are the basic two reasons why we use physio dispenser for placement of implant. Now, when we are going to drill implants, when we are drilling to create an osteotomy, the range of speed is kept between 800 to 1200 revolutions per second, 8 to 1200 RPM. Torque can be kept around 20 or 30. Torque is not that significant when we are drilling. So I will start. This is a model I have in my hand, which has, I think, 6 missing, first molar missing. What I will do is, I will start with the lancet drill. It's push. You just need to push it and it gets locked in its place. There is foot control. I have kept my settings at 900 RPM. Since there is no saline, I'll just put off the irrigation pump. There is a pump in this physio dispenser which forcefully pushes the saline for irrigation. So I have just switched it off because we do not have saline here. Now what I will do, I will try to mark my osteotomy site. Is it visible there back there? So I'm just starting the procedure. See, it's not slipping at all. When I'm making it, when I'm drilling with lancet drill, it's not slipping at all. I have marked my initial osteotomy site. Now, purpose of lancet drill is done. We are going to place 4 by 10 mm implant. So when I take my initial or 2 mm drill, I'll place a stopper that is 10 mm. Now whatever part that is visible or available for cutting is 10 millimeters in length. I'm just starting the drill. When we are drilling to place an implant, we do not drill unidirectionally. Why we do not drill unidirectionally? Because when we take out the burr from the osteotomy, irrigant has chance to flow inside. It reduces friction, reduces temperature. I'm just drilling. This is a very good model. It will give you a feel of cortical and inside soft cancellous bone. So I am just doing it in pumping motion. See, when I have reached 10 millimeters, I cannot drill any further because stopper has stopped. That is a very good feature of this implant system. Now there is something else we have here called paralleling pins or guide pins. These pins can be used to check parallelism. After initial osteotomy, I can insert this and see whether my osteotomy is parallel or not. In case if it is not parallel, I have to attempt to correct it with the subsequent drill. But fortunately, this is parallel to the adjacent tooth. Can you see this? So I have checked parallelism because implant should go in parallel to the adjacent teeth, and this is fairly parallel. So what I will do, I will start with the next drill. Next drill is 3.3, because we will go sequentially till 4 by 10. So implant length is 10. First drill, I will use 3.3 by 10 mm drill. Again, in the same manner, I will try to keep it parallel. When you are looking for parallelism, what we advise beginners is that you check parallelism from both sides, from the side as well as from the front. Now, one person cannot do it. You cannot see from both hands at the same time. So we ask beginners to have an assistant or a helping hand standing in the front, so that they will tell if they are tilting in buccolingual direction and mesiodistal direction. The operator can see by him or herself. Now we are widening the osteotomy. Again, drilling in pumping motion. Now sometimes what happens is your handpiece gets stuck in the adjacent tooth. To remedy this problem, DO provides you with a drill extender. You can simply place it here and your drill will get engaged in the extender like this, and you can drill without any obstruction. And see, when I have reached 10 mm, I cannot drill any further with this drill because there is auto stopper. So I have expanded it to 3.3. Now, next drill is 3.8. Again, in the same manner, being mindful about the parallelism. Sir, is it parallel from buccolingual? And now I have come to the final drill, that is 4 by 10. The DO maintains 0.8 mm difference between the final implant size and the osteotomy. So this drill is designed for 4 mm implant. That means its actual diameter is 3.2 millimeters. This way, our final osteotomy is complete, right? Can we zoom in on this? This is the final osteotomy in the center of residual alveolar ridge and most certainly parallel to the adjacent teeth in both the directions. That means in all three dimensions. Right? Is it visible? Now, next step is to place implant. Now, when you are placing implant with the help of physio dispenser, you keep the torque around 20 NCM and you keep the rotation between 50 to 90 RPM per minute, revolutions per minute. What we do is, this is the packaging, just open it like this. Okay, then you are not supposed to touch the implant by hand, or even when you are wearing a sterile glove, you are not supposed to touch the implant. Why? Very nice. You're really good audience, you know, very attentive. And when you're picking out fixture, in any case, you're not supposed to do it like this. Because it is by chance, it may happen that the fixture might not have locked in your drill properly. So whenever you're taking an implant, be it for maxilla or mandible, using it with the handpiece one or the manual hex driver, you are supposed to take implant like this. And when you reach the osteotomy site, then only you are supposed to change the direction. Now, I have kept torque at a very low, around 10 to 20 NCM range. Why? Because I do not know how much torque I'm going to get. If I have set the torque more than what torque can be achieved with this kind of bone, I might, what you call over rotate, end up over rotating the implants. So while inserting, torque is advised to be kept very lower. This is how we are going to insert. At some point, it will stop because torque was low. That is fine. Detach it. Take out your manual driver. Attach it here. Take the wrench. Now when you look at the wrench closely, there is an arrow here that will show which direction the wrench will tighten. So arrow is showing this direction. Implants get tightened on a clockwise motion. Anti-clockwise में tight नहीं होता, फिर वो loose होने लगता है. So place it, give support so that you do not change the alignment of implant while tightening, and keep on tightening it. I'm sorry. Keep on tightening it. You are supposed to place the implant at least at the level of bone and desirably 1 millimeter below the level of crest of alveolar bone. Now I have done the final tightening. Now I was talking about the torque measurement. This will be visible shortly. See this, there are markings in this 15, 35, 50. When you pull this during final tightening, if you keep on pulling it, at some point it stops moving. You see that? यहाँ तक खींचा नहीं घूमा, थोड़ा खींचा घूमा फिर रुक गया. जहां पे रुक जाता है वहां पे आपको मेजरमेंट लेना है. So I am getting torque roughly around 30 NCM with this implant. So that is my insertion torque value. If I pull it beyond 30, it starts rotating. That means the value of torque is, insertion torque is 30. This is placement of implant. Now we have placed an implant. In one stage surgery, what will we do? We'll place a cover screw and close the flap and submerge it. In two stage surgery, and in one stage surgery, some part of it will be visible. Whatever the thing is, after we have placed the implant, when either one stage or two stage, after healing, we have to provide prosthesis. For that, we have to make impression. Now here in my hand, I have two impression copings. We were discussing about the impression copings, right? This one that I'm holding is an open tray impression coping. It has what you call block here that will engage in the impression, so that when we are picking impression, this thing will come off with the impression. And this one I'm holding in my hand is a closed tray impression coping. This will not come off with the impression. We have to take the impression out after making, and then we have to unscrew it and place it in the impression. So I will start with closed tray impression technique first. I'll use the hex driver. एक ट्रे सर, एक बिना कटी वाली ट्रे भी चल जाएगी. Till this point, everything is clear. Is there any doubt? See, I have placed the coping. Tightened it with the screw. Now it's securely placed on top of implant. तब नया नया इम्प्रेशन मटेरियल आया है ना. These two components are provided with two different spoons or scoops is the better word, because we are not supposed to mix them unless we want to make an impression. I will just take a small amount because I'm going to make an impression of this is needing to ठीक है. मटेरियल कौन सा है? Heavy body, right? और यहाँ पे we have light body. I'll just mix it thoroughly so that there are no white streaks visible. I've loaded it here. I'm taking the light body. I'll put the light body around my implant and the coping. And then I will place. I'm feeling a little scared. No, so many prosthodontists are sitting around me. And me being a periodontist talking about impression technique, I'm feeling little out of place here. Anyways, we'll wait for it to set. How do you know where your material is set? You can take the excess material, make a ball, throw it. If it bounces, it's set. If it does not bounce, you have to wait a little longer. क्या हुआ? क्या जोक है? हमको भी बताओ. Indentation is another method. You can press it and see if there is deformity or indentation. If it is there, then it's not set. पर उसके लिए नाखून बड़े चाहिए. That's there. देखो, prosthodontist input is always important, you know. सर, हाँ नहीं, इनको तो जस्ट ऐसे ही बताया. थोड़ा थोड़ा से में ही हो जाएगा सर. 3 पर है. So my ball is bouncing. I guess it's set. There are no indentations too. बहुत है सर ठीक है कोई issue नहीं. Now I'm taking my impression out. My God, it has come out from the tray itself. No problem. We can repeat such impressions when we are doing on the patient, but in hands-on it's fine. See, I have got a hole for coping. Now what we'll do next step is to unscrew the scooping. Remove it from the implant. And this is something, it is called implant analog. It mimics the implant for lab procedures. I'll attach an implant analog here. And then I'll place the coping back. Now see, the coping has two flat sides. That is for identifying the correct spot in the impression material. Flat side should go on the flatter side of impression material. Now when I pour a cast, what will happen? This entire metallic component will come out and it will replicate exactly all the angulations and position of implant in a cast. Then we can place an abutment and fabricate a restoration. This is closed tray impression material. Now we'll see open tray impression material. For that we use open tray copings. We attach the coping. We have attached, we have cut a section of tray here so that this screw can pop out. When we take impression, we have to unscrew this while taking out because this coping is supposed to come out with impression. It's also called pickup impression. I'll take some amount of, sir, I think we'll have to change the tip uska applicator tip badalna padega. In similar manner, we'll load the light body and heavy body. Screw will be visible. We'll wait for the material to set. ये तीन लड़कियों का आपस में कुछ ना कुछ चल रहा है. क्या बात चल रही है? नहीं हुआ सेट. बच्चा है. This is one part that is boring, right? Waiting for material to set. It's set sufficiently. Once it's set, we'll unscrew it from here. Sorry. I'll just use the lancet drill to take the impression material out from the hole. You unscrew. Now you are not able to see the what you call coping. So how do you know whether you have completely unscrewed or not? What happens is when you are unscrewing, when screw is completely out of the threads of implant threads, you get a click sound. You feel a tuck sound here. You won't be able to appreciate it from that far, but when you'll be doing, you'll feel a click here. That click means that screw has completely come out of the implant's threads. Now I'll take out the entire assembly, and coping has come out with impression. Now we can attach a analog on this and then send it to the lab for pouring and fabrication of prosthesis. जरूरी क्राउन बने, हम कुछ और भी बनवा सकते हैं. Analog is placed here, attached, and screwed on coping. Now if you see, the coping has very firmly anchored in the impression material. That is because of that jack that was present. निकला हुआ था ना थोड़ा सा coping से. That helps it grip inside the impression so that it comes off with the tray when you're taking out impression with the you're taking out. So these are the two impression techniques used in implant dentistry: open tray and closed tray. Now we have seen, we'll start with the starter drill, marked here starter drill, which is a lancet drill. Then we'll move on to 2mm drill. Then sequentially move on to 4mm drill and place the implant with fixture drivers. So we should start, we are ready to start with the hands-on. Sir will be there, I think, with me. Let's divide, split up and proceed. It's your turn to do the honors now. Any doubts? वो माइक्रो मोटर अरेंज करने में सर माइक्रो मोटर अपन लगाएंगे तो माइक्रो मोटर से करा देते 3-4 पार्टिसिपेंट एक दो का एक साथ एटलीस्ट फिजियो से कराएंगे तो बहुत टाइम लग जाएगा सर इनको ग्रुप बना देते हैं These are not dummy kits. These are original kits that are used to place implants. So please be careful with the small drills. वो वाली किट दिखाओ, डेंशिंग वाले। हाँ, तो ड्राइवर को सब एक किट में है, ये वाले तो ये किट हटा दो साइड आप
जैसे ये है ना, उसको तो ये पिंक वाला दिख रहा है, ये पिंक वाला ऑनलाइन मेरे को नहीं दे रहा होगा।
कॉन्टैक्ट पे मटेरियल प्रेजेंटेशन
फ्लो करवाते हैं, फिर वो डाल देते हैं।
ठीक
बिल्कुल सेंटर पे रखना है, ठीक है। ये चीज ध्यान रखना, अगर आप मैंडिबल कर रहे होते हैं तो हमेशा जो एंगुलेशन होता है तो कम बकल क्यों, क्योंकि आपका मैंडिबल है इस शेप का हो सकता है कई बार स्ट्रेट डालने से तुम्हारा नीचे ऊपर तक निकल जाए, इसलिए हमेशा बकल तो लिंगल जाता है मैंडिबल में, और मैक्सिला में निकल जाएंगे मतलब